I would like us to start. And just before we start, are there any Sierra Leoneans in the audience? Okay, stand up for Sierra Leone. And I want the whole audience to please stand up for Sierra Leone, because today is their Independence Day. So let's give them. That is that. So we have, as we have been talking, we have liberation in many forms. So we've got a great afternoon for you. We're going to be looking at some new things, learning from old things, and we'll be finishing up with a really exciting session looking at the commitments that our national governments are making in our attempts to accelerate this agenda. But we're going to start with a panel that's going to actually be looking at antibiotic access in an era of excess. And so please welcome to the stage with her panel, Dr. Yodi Tesfaye.
Thank you, Theo. Good afternoon, everyone. Welcome and thank you for joining our panelists. Our topic for discussion is antibiotics access in an era of excess, focusing on how to ensure children with pneumonia are treated properly. With increasing coverage of vaccine targeting the leading bacterial cause of pneumonia, the relative burden of viral cause of pneumonia is rising. And as we heard from this morning in Champ's finding from yesterday's presentation, evidence is showing that the viral cause of pneumonia is increasing significantly, which leads on reduction of need for antibiotics. This is happening despite the fact that we are having a significant access issue itself. For example, according to WHO, only 1/3 of children with pneumonia have getting an access for amoxicillin or antibiotics treatment. Not only that, evidence also suggests that in many low-resource settings, children are regularly prescribed antibiotics while access is limited. So the question will be, how do government targets WHO recommended antibiotics, for example, amoxicillin dispersible tablet and other antibiotics lower in price, convenient for logistics management, to reach to children most likely to benefit while restricting overuse, which can ensure a rational use of medicine, effective utilization of resource, as well as sustainable or effective treatment of childhood pneumonia. Please allow me to introduce my panelists to address and share their perspective, experience, and findings from the study they conducted in different setups. The first panelist will be Dr. Charles Sentner, who is a technical officer of antimicrobial resistance from World Health Organization. We have Professor Cicely Kartasamita, who is a director of Center for Collaborative Research on Acute Respiratory Infection, Faculty of Medicine, Pajajaran University, Indonesia. We also have Dr. Zement Gabu, Director for Enhanced Management of Pneumonia in Community Study, School of Medicine, Department of Pediatrics and Child Health, University of Gondar from Ethiopia. And we have Jane Bridge, who is a Senior Principal Technical Advisor from USAID Medicine Technology and Pharmaceutical Service MTAPS, implemented by MSH program from USA. Moving to our question for Dr. Chad. WHO has prioritized the fight against antimicrobial resistance, warning that countries should focus on it now, unless it could become a major cause of death in its own, including among children. So, what is your message to those 14 countries in the House delegate in the room we have today And what are the 3 things should they do to prevent this crisis?
Thank you for having me here to represent the Antimicrobial Resistance Division at WHO. Estimates on deaths associated with antimicrobial resistance reported by The Lancet suggest that 5 million deaths per year are associated with antimicrobial resistance, which is more than HIV, TB, and malaria combined. And the highest rates were in sub-Saharan Africa. However, that's just the beginning, because it's estimated that by 2050, there will be 10 million deaths per year associated directly with antimicrobial resistance. So antimicrobials are becoming less effective. What can governments do? I want to highlight 3 things. Firstly, and most importantly, every government needs to implement their National Action Plan on Antimicrobial Resistance with a structured governance approach that is funded, that is monitored, and that is sanctioned, and is part of a One Health approach that includes the healthcare sector, human healthcare sector, animal sector, and agriculture sector. And that would be according to the tripartite agreement that was endorsed at the 72nd World Health Assembly. So governments can monitor the implementation of their national action plans by participating in the Tracking Antimicrobial Resistance Country Self-Assessment Surveys, or TRACS. Despite enrolling in these surveys, 50% of countries report not actually using the information to monitor the implementation of the National Action Plan. So I've brought along reports for 13 of the 14 countries represented here, and you're welcome to come and collect them, and we can discuss further. Secondly, antimicrobial resistance is driven by excessive antimicrobial use. But the extent of this is unknown. So governments need to monitor and report their use of antimicrobials in communities and in healthcare settings. WHO has developed the Global Antimicrobial Surveillance System platform to collect these data. If you want to enroll in the GLASS platform for antimicrobial use, all you need to do is write a letter of intent that is government sanctioned, nominate a focal point, and designate an agency to monitor consumption. WHO can help you by supporting the development of a surveillance program, collecting and analyzing data, and providing implementation and training tools. So in addition to monitoring antimicrobial use, we also need to we need to strengthen surveillance for antimicrobial resistant infections, so that we have a baseline from which to monitor improvements. So again, I've included some reports for some countries that you can pick up later. So my final point is that we need to raise awareness about antimicrobial resistance, starting from the youngest citizens onwards. We need to include antimicrobial resistance in school curricula. We welcome participation in the World Antimicrobial Resistance Awareness Week, which is from 18th to 24th November. Everybody needs to know that antimicrobial resistance is a major threat that is currently underestimated. Imagine a world where childhood pneumonia is untreatable.
Thank you so much, Dr. Chad. Moving to Professor Sisley. You published a major study of antibiotics resistance on streptococcal pneumonia in Indonesia. Can you share major findings from that study, please?
Okay, thank you, Jody. Good afternoon, everyone. Ladies and gentlemen, the title of our study is the Epidemiology, Nasopharyngeal Carriage, Serotype Prevalence, and Antibiotic Resistance of Streptococcus pneumonia in Indonesia. It was published in 2020 in Infectious Disease and Therapy Journal. The study was a literature review of 13 out of 33 publications that meet the title in Indonesia. We found that the pneumococcal diseases cause a substantial health burden in Indonesia. And also we found the pneumococcal nasopharyngeal carriage prevalence is approximately 43% to 55% in healthy under 5 years old children, and between 38% and 60% of isolates were covered by the PCV13. As we know, in Indonesia, the PCV vaccination introduction was started in 2017 by the demonstration program starting in province Lombok, East and West province, and then followed by other province. And last year, September 2022, this became a nationwide program. About the antimicrobial resistance. A study on nasopharyngeal carriage in Lombok in 1997 found that 12% of the isolate were resistant to one of the 4 antibiotics tested. However, none were resistant to all antibiotics. 100% at the time were susceptible to penicillin and 91% to cotrimoxazole. But a study 15 years later in 2014 in the same area, the penicillin susceptibility decreased to 72%, and for the cotrimoxazole decreased to 38%. Yeah? So it showed that a decrease in the susceptibility to the common antibiotic use. A study on nasopharyngeal carriage in Semarang, Semarang is in Central Java, in 2014, found that 24% of Streptococcus pneumonia serotype resistant to penicillin and 45% resistant to sulfamethoxazole trimethoprim. In its IV patient in Jakarta in 2014, the study found in children 67% isolate resistant to penicillin, 59% resistant to sulfamethoxazole trimethoprim, and 38% showed multi-drug resistance. In adult, it was found for the penicillin 45%, for cotrimoxazole resistant 85%, and 45% multi-drug resistant. So all the studies showed a decrease in susceptibility to common antibiotic use for pneumonia in Indonesia. Thank you.
Thank you so much, Professor Sisley. Moving to Dr. Zaman Gabo, many children are dying because of lack of access to antibiotics, especially from pneumonia. You lead a large trial in Ethiopia, the enhanced management of pneumonia in the community EPEC study. What do you learn about access to antibiotics among those sick children?
Okay, thank you very much, the organizer and the moderator, to giving me the chance. So let me say briefly about this EPEC study short. This study is actually aiming to answer whether the community health worker can treat chest and drawing pneumonia at the community level. WHO recommends to treat pneumonia with chest and drawing at the health facility level, but can this be done at the community level with community level health workers, the health extension workers in the context of Ethiopia? And in fact, for those aged 2 months to 59 months, and for young infants 0 to 2 months, to check if the community level health workers can treat fast breathing pneumonia in the absence of any of the general danger sign and non-hypoxemic young infants and children in both cases. And then this study was done in 4 countries, 2 in Africa, Ethiopia and Malawi, and 2 in Asia, India and Bangladesh, and led by WHO, coordinated by WHO headquarters, and the results showed that this treating this enhanced or the enhanced approach is not inferior to the standard approach, and that was a result. And coming to the question to others, yes, still pneumonia is the leading cause, despite the vaccine coverage and the change in strategies. Still, pneumonia is the leading cause of under 5 mortality in Ethiopia. And the access issue, it can be limited access or at the same time over accessed, overused. So in the village, in those poor where they need it most, the access is limited because of the infrastructure issue, the transportation issue, and then also the demand. I think there should be a demand generation because they should go to the place where this antibiotic is available, because the setting is scattered in Ethiopian setting, and then to reach into that village level household is really somehow limited. But at the same time, these antibiotics is being overused in the town and in the cities. Like you can say, this amoxicillin would be available even without prescription, like over-the-counter medicines. So those in the village or in the poor who needs it most, it is inaccessible. It is not well accessed. Thank you very much.
Thanks so much, Dr. Zaman. Moving to Jane Bridge, your work with the SIDE MTAPS program in the DRC, where the government has adopted some of the tools you have created to improve antibiotics prescription by healthcare workers and appropriate use by family. Can you tell us about them and show us some example as well?
Yes. So first of all, I'm very excited to be here at this forum and feel the energy around treatment and prevention of pneumonia. But I must say I'm actually disappointed to be sitting on this stage because I'm actually representing my colleague, Cesar Kasongo, who was supposed to be presenting in this session from DRC. So I'm speaking on his behalf. But turning to your question, obviously appropriate use of amoxicillin as first-line antibiotic for children with pneumonia is very important, not only to reduce mortality from pneumonia, but also to address the development of antimicrobial resistance, as we've heard from the other panelists. And when I'm talking about use of amoxicillin, I don't just mean by the healthcare providers, but also by the caregivers of the sick children. So building on what Dr. Jean-Fidèle Ilunga from DRC mentioned yesterday about how DRC had developed guidelines and policies around the management of pneumonia, MTAPS is a partner of the ministry there, and we have supported the ministry in operationalizing those guidelines through the introduction of some job aids and training providers. So in early 2022, the ministry took some generic job aids for pneumonia that had been developed by a group of global partners, some of which are here today, and they adapted them to the country context and adopted them as official tools. So this is an example. And obviously that process of adapting and contextualizing tools that were developed at a global level is very important for country ownership. So these job aids are intended for use by healthcare providers, both at the facility level and at the community level. And they orient the providers in selecting and prescribing the treatment for pneumonia, as well as the messages to communicate to the mothers. So we work in 2 provinces in DRC, North Kivu and Ituri, and we helped to train staff from the provincial and health zone teams to train them as trainers, who then went on to train healthcare providers in the management of pneumonia and disseminated these job aids. The rate of correct treatment of pneumonia according to the national protocol, which is the indicator in the DHIS2 system there, is currently, or was, 99% in North Kivu and 95% in Ituri, according to DHIS2 data from the second half of 2022. The ministry also considered adopting some dispensing envelopes, which were also developed at the global level some years back by the same group of global partners. They considered these job aids for use to help mothers in administering dispersible tablets to their children. But the funding for adopting those and rolling that out was not available at the time. So that's still something that's on hold. But there are results from studies in DRC and other countries that these types of dispensing aids can be helpful in orienting mothers on how to provide the treatment, the frequency of the dosing, empowering them in administering the treatment, thereby improving adherence. So just quickly, I want to go back to optimizing use of antimicrobials and touching on a couple of things that Chad mentioned. In DRC, they've been working very hard to integrate the WHO AWARE classification of antibiotics into the National Essential Medicines list. And this classification of antibiotics groups them into antibiotics that should be readily accessible, such as amoxicillin, those that need to be watched or used more carefully, and those that are reserved for special context. And this limiting of the way antimicrobials are used can help to slow the development of AMR, and ideally encouraging the use of the antibiotics from the accessible group and watching and reserving other antibiotics. And we've helped to establish medicines and therapeutics committees in 12 pilot hospitals. And their role is really to supervise and monitor the use of antimicrobials. And from a recent evaluation in 4 of those hospitals, the use of antibiotics from the access group, where amoxicillin is, has improved from 40% in 2021 to 60%, over 60% in February of this year. And that's aligned with the recommendations from WHO. So in summary, train providers, equip them with tools. Mothers should be taught how to administer the treatment. And let's use a strategy such as the AWARE classification and the use of medicines and therapeutics committees to really oversee the prescribing of antimicrobials. Thanks.
Thank you so much, Jane. Coming back to Dr. Chad, how should government be thinking about the trade-off between antibiotics access and the high price of excess? What type of policy ensure children get the treatment they need without overuse of these antibiotics?
So there are a number of policies that get the balance right. And the first one I was going to mention was the AWARE classification. So I couldn't really explain it better, but it's just important to emphasize that the narrowest spectrum antibiotic is the one that is least likely to cause resistance in other bacteria in the short term and long term. So we need to prioritize access to the narrow spectrum antibiotics. The second policy is to improve diagnostic capacity. So to assist countries to develop and strengthen the laboratory services for the identification of antimicrobial resistance, WHO is developing a strategic framework which will, for example, outline the minimum package of tests that should be available at each level of the health system. And these results could, for example, guide healthcare workers to select the best antibiotic for a particular patient, or to identify resistant infections, alert infection prevention control personnel so that they can initiate procedures to contain the infection and prevent its spread to other people. And then we need to develop a point-of-care diagnostic, like a pregnancy test or TB COVID antigen test, which will differentiate viral infection from bacterial infection or malaria. And this will reduce the number of antibiotic prescriptions, which will then reduce the amount of antimicrobial resistance. So WHO is currently, together with partners, developing a guideline or target product profile for the development and use of such a test. So the test needs to be available at all levels of the healthcare system, require minimal training. It needs to be easy to procure and low cost. And these guidelines will be available for public comment.
Thanks so much, Dr. Chad. Moving to Professor Sisley, how successful is vaccination as a strategy to reduce antibiotic resistance to pneumonia pathogens?
Thank you, Jody. Yes, as we know that there is a role of vaccine in combating antimicrobial resistance. Vaccine is a powerful tool to fight AMR. Vaccine can reduce antimicrobial resistance through two ways, the primary and secondary, the direct and the indirect effect. So for the direct effect, it's the example is the PCV, vaccine against bacterial pathogen. So all the effect after vaccination, we can see the decrease of the incidence of infectious diseases such as pneumonia, meningitis, or middle ear infection due to Streptococcus pneumonia. And we also seen the decrease of antimicrobial treatment because of the use of antibiotic also decrease. Yeah? And also vaccination can decrease the nasopharyngeal carriage, the colonization of the Streptococcus pneumonia in the nasopharynx, that it will stop the transmission, of course, yeah, and it will also to protect the vaccinated children against pneumonia or the other bacteria pathogen from the vaccine. Yeah? And for the second ways is the indirect, is for such vaccine for influenza, or the vaccine for viral. So if we give vaccination to children or to somebody with influenza vaccine, then the febrile illness will become decrease. So usually, if somebody gets fever, doctor or they will take antibiotic. So if the febrile illness is decreased, then the use of antibiotic, the misuse, the not necessary antibiotic also will decrease, and hopefully they will also protect the resistance of antimicrobial that usually used for the common infection. For the additional information in Indonesia, after 1 year after the started of the PCV introduction in Lombok and East Lombok and West Lombok, the report from the field found that the incidence of pneumonia in the field decreased. And then it almost 50% decreasing. And also the study after 1 year after the demonstration program found that the nasopharyngeal carriage serotype, vaccine serotype in vaccinated children lower, much lower compared to the non-vaccinated children. Thank you.
Thanks so much, Professor Susli. Moving to Dr. Zaman, can you tell us about Ethiopia's experience with the WHO recommended childhood pneumonia treatment, amoxicillin dispersible tablet, and injectable gentamicin and ampicillin for hospitalized setup? Are supplies available? Are this medicine imported? Does the government have a clear plan to manufacture them locally? What roles do international donors can play on alleviating the current challenge?
Okay, thank you very much again. So regarding to the management of pneumonia, the guideline is as per the WHO recommendation. That means pure dispersible amoxicillin for pneumonia and ampicillin gentamicin for severe and complicated pneumonia at the health facility setting. But regarding to the availability issue, the dispersible amoxicillin tablet is not sustainably available because the country produce the syrup or the powder in the ampule form, and this tablet or dispersible is not readily available, and it is imported and mainly by NGOs like UNICEF, those NGOs working in pediatric or CBNC program. Then they donated that tablet, but it is not evenly distributed to the community, and sometimes there could be a shortage. And regarding to the manufacturing, how is the government plan? I think it has been discussed before, and then not done. I don't know. Probably the reason is one, there are criteria put to produce this tablet or dispersible tablet as per the WHO recommendation, and the other, the issue of marketing may not be as comparable as the powder or ampule form. So this sustainable marketing issue could be the question from the manufacturing company side. That is the point. So if there is a new one from the international donor or a manufacturing company, if there is anyone interested to produce or manufacture this tablet, I think labor cost is cheap in Ethiopia, and the policy is open to actually invest in Ethiopia, so it would be open. But so far, we don't have this tablet form, and the injection as well, ampicillin and gentamicin, it is imported, not being produced in the country.
Okay. Thanks so much, Dr. Zaman. Last question goes to Ms. Jane. You have something very important to share today, a call to action to improve access and use of quality medicine for children. What can you tell us about it, and how can we all support that? And I think we have a slide to share. Maybe the team can help us on that.
Yes, thank you. So I think this follows very nicely on what my colleagues have presented, that we have to do something, and there are clear actions that we need to take to make quality amoxicillin accessible to children with respiratory infections in child-friendly formulations, dispersible tablets, and make sure that it's used properly. And sadly, we've been talking about this since 2014, was it, when WHO released the recommendation for use of amoxicillin for pneumonia? And yet we're still talking about children dying from pneumonia. And despite the efforts of the UN Commission on Life-Saving Commodities 10 years ago, amoxicillin is still not widely available, as we've just heard, in pediatric formulations. And if it is, it's not used appropriately by the providers or the caregivers. And so there are solutions, and they're simple and they're practical. And so I'm going to skip to showing you what this call to action is. And you can see here on the slide, there's a QR code to access it. And it's also available as a resource on the Stop Pneumonia site for this conference. This is a set of practical steps that have been developed as a collaborative process between UNICEF, USAID, the Child Health Task Force, and 3 USAID implementing partners working on projects to improve supply chains, to improve quality of medicines and strengthen pharmaceutical systems, as well as other partners that are also here present today. And it identifies 4 key barriers to access to amoxicillin, and they're laid out inside. Barriers related to quantification and the fact that there are problems of estimating the amount of amoxicillin that's needed to ensure that healthcare providers have the medicines at the level that they need to have them. And so we need better use of data, better collection of data to improve our forecasting and our supply planning. And there's examples of that in DRC that my colleague would have spoken to in more detail, where the Centralized Drug Supply Program, the PNAM, is coordinating the quantification exercise. And then we're supporting technical working groups up country to work on the distribution plans to make sure that amoxicillin is part of the package for an integrated community case management. There are other barriers as well. In the document, you'll see that secondly, we talk about lack of funding, and I think that's the subject of the next panel, so I'll not go into that. But obviously, funding is essential for the procurement of amoxicillin. There is a really important opportunity that has just been announced by the Global Fund that they will fund the inclusion of non-malaria commodities for community case management. So that does include amoxicillin, and for example, DRC did include that in their first proposal draft that they submitted to the Global Fund just at the end of March. There are obviously other ways of looking at financing, and I'll let the panel that follows talk about that. Another barrier in here is about quality. 10% of medicines that reach users in low and middle income countries are substandard and falsified. And obviously that doesn't only put lives at risk because the pneumonia is not getting treated, but it also contributes to antimicrobial resistance. So we need to work to strengthen regulatory agencies to ensure the quality of amoxicillin and make sure that when it's procured, the quality is considered and not just the price. And the last barrier is about following guidelines and the appropriate use of amoxicillin. And there's a variety of interventions included there, some of which I touched on earlier. So the call to action is available in English, French, Spanish, and Portuguese. We do have some copies here today, so if you're interested in a copy, do come up to me and I can give you a copy of that. It's downloadable on that link. I think at your country level, we would encourage you to take this and introduce it as a theme in the child health working groups that you have. In the next meeting, discuss what your barriers are to access to amoxicillin, look at the actions that are proposed in this call to action, and identify which of those actions are kind of low-hanging fruit to start on to improve the situation of access to amoxicillin in your countries. Let's get amoxicillin and access to amoxicillin back on the child health agenda. Thanks.
Thanks so much, Jane. You summarized it very well as well. So thank you for taking my role. So without further ado, I will try to summarize it in a few points. Countries need to start planning for AMR, and then that should be a priority for all the countries, given the challenge as well as the consequence in the near future will be very much unreversible. So we acknowledge the importance of national plan for AMR, and then advocacy and awareness creation among community healthcare provider as well as at a national level about antibiotics use and its funding as well. So I will close this session, given we take few additional minutes. Apologies, Ms. Leo. So thank you everyone for attending this session.
Thank you.
Thank you very much to Yodi and her panel for so beautifully raising the challenges, but also the opportunities and the strategies. They actually set up the next panel very easily for me because the next subject is a subject that has been coming up throughout these 2 days that we've been discussing, which is actually on the financing of child survival. So it's a great pleasure for me to introduce Ms. Jinji Song, who will be moderating the session. Jinji, thank you.
Hi, good afternoon, everyone, and thank you for joining our panel on financing child survival. We've heard in the last 2 days from governments and partners about their plans to drastically reduce child mortality in the years remaining to 2030. But with national government and foreign aid budgets stretched thinly, how will governments finance these actions to achieve SDG Goal 3.2? And how will global health donors and agencies support this agenda and provide the flexibility needed to prioritize child health and deliver integrated services with the fastest results? I have with us our panelists and our colleagues on stage who represent various health agencies and donors, and will talk to us today about the availability of financing that's targeted at child survival and how national governments and their partners can effectively access this support. It is my pleasure to introduce Dr. Nicholas Furtado, Advisor on Medical Oxygen and Respiratory Care for the Global Fund, Ms. Carolina Kwok, Associate Director of Global Health Innovation from Grand Challenges Canada, Mr. Robert Matiru, Director of Programs from Unitaid, and Mr. John Paul Clark, Lead Health Specialist from the World Bank, as well as the Lead Advisor for Global Financing Facility, GFF. And joining us via video later in the session, Ms. Gabriela Jesus, Director General for International Partnerships at the European Commission. My name is Jingyi Song, and I lead the Oxygen portfolio at Alma Philanthropies. For those who are not familiar with our work, Alma Philanthropies is a private foundation with a focus, with our main mission focused on improving the lives of children in Africa. We have a long history of funding child health from many different angles, including supporting the workforce, supporting the child workforce, maternal and newborn health, with a strong focus on taking care of small and sick newborns, and early childhood development targeting the first 1,000 days of life. We also work to improve vaccine coverage and equity for children with a new commitment towards finding zero-dose children. Through our earlier diagnostics and newborn work, we quickly realized that a lack of access to oxygen and ensuring its safe usage for newborns was one of the main drivers of child mortality. A study conducted by the Clinton Health Access Initiative in Uganda showed that of all the child deaths recorded during the study, 56% of those children were found to be hypoxemic before death. And this corresponds to the CHAMPS data presented yesterday, where, even when children are able to access antibiotics or get to the facility in time, they're still often not able to access life-saving treatment, and in this case, due to a lack of pulse oximeters, oxygen supply, or trained staff to manage these cases. Alongside Bill and Melinda Gates Foundation, we currently work with CHAI, PATH, and the Every Breath Counts Coalition to support 17 governments across Africa and Asia to build sustainable oxygen ecosystems. This work leverages off of the unprecedented influx of oxygen plants and equipment during COVID-19 and the strong coordination built between governments and donors, including our colleagues on stage, to ensure that clinicians are trained and accurately diagnose and manage hypoxemic cases. Biomedical engineers are equipped to operate and maintain the plants, and that oxygen data is integrated into health management information systems. There is much work still to be done, and we welcome others to join us in this continued fight to ensure that every child is able to access safe and affordable oxygen for many years to come. With that, let me dive right into the questions for our panelists. Nick, I'd like to start off with you. So we all know that the Global Fund is one of the largest sources of external funding for for health in general. And during the pandemic, the fund provided a great deal of support for COVID-19 diagnostic tools and treatments, so including pulse oximeters, ventilators, oxygen plants. And so will the fund continue to offer this type of support? And what is your advice to ministers of health seeking to partner with the fund?
Thanks a lot, Jingji. And let me start by thanking the organizers, thanking LATE, Every Breath Counts, UNICEF, CHAI, PATH, all our colleagues who and many more here who, United, Robert, and so many more who've been with us in this fight. And you're absolutely right. Since 2020, the Global Fund, in addition to the main mandate for what the mission that we are supposed to be there for, we decided to pivot towards the response for the pandemic, the COVID-19 pandemic. And so there was unprecedented, as you say, influx of funds, and oxygen respiratory care is a major part of that. So since 2020, with the help of all the multi-stakeholder partnership that we are, governments, the money we get is not our money. It belongs to the citizens of the countries who are eligible for Global Fund grants. And so it's ministries that have actually prioritized oxygen and respiratory care within their grants and the funding requests to the Global Fund. So the investments that we have made have been investments that that ministries of health have prioritized. It's not our priorities, but it was a global priority, and the individual funding requests come from countries. The entire approval process was helped by a lot of our partners, USAID, CHAI, PATH, all of them were brought in to actually make sure that these were the correct prioritizations. So that has led to almost $590 million of oxygen respiratory care investments. But as we all know here, that's not enough. Not enough to just buy yourself out of. You can't have just equipment landing there. And as you mentioned in the introduction, we are at this point where there are all these massive capital investments that have been made, but what is the wraparound as we are talking about these days? What are the systems that are needed for this? And so we have put in place the same mechanism that exists has been extended for the next 2 years. So the COVID-19 response mechanisms, as it was called, is extended for another 2 years through our board that has approved it till 2025. So there's more time to make sure that the systems pieces are in place. In addition, along with our partners, we agreed to put the capacity or the entry point for ministries to also place oxygen respiratory care investments all the way from bulk oxygen supply source all the way down to delivery and medical devices within their health systems grants within the next funding cycle for HIV, TB, malaria. So with that, and they're going to be overlapping by 1 year. So the COVID-19 response mechanism goes to 2025. The new funding cycle goes to 2026. And both will have the possibilities. And our advice is not to focus on bulk capital expenditure unless it's absolutely necessary, but to focus on the wrapper, on what are the needs to make sure that this massive investment is actually going to provide oxygen and care for the children under 5, et cetera. So, and mothers, so oxygen and respiratory is agnostic, except for the medical devices, which have to be tailored to neonatal, pediatric, and adult kind of care. But oxygen per se is agnostic. It can be used for anything, from non-communicable diseases, acute pneumonia for children, neonatal care, et cetera, et cetera. It just goes on. So I think we need this equipment and medical devices that we have approved so far to now be sustained for the next 5 to 10 years. In Nigeria, they use plants for 20 years. So we want to have ministries now focus on these additional items, list those equipment, track that equipment, maintain them, provide the human resources for operating, maintaining, servicing them, et cetera, et cetera. So I think that's my advice. So in the new grants and in the new opportunities, make sure you fund or prioritize the systems pieces for this. Now that we have already put in the capital investments and prioritizations on that. So I'll stop at that.
Thank you, Nick. That's great advice. And we appreciate you doing the shout out to the ministries of health who are, really leading the work. And thank you. So let me move on to Carolina. You've seen that many countries in the room have had to move at sort of 5 times the pace to reach the SDGs. Grand Challenges Canada has developed a reputation for backing innovations that can save lives. What types of innovations do you think are going to be most impactful for child survival in the years to come?
Thanks, Jing. And thanks for the organizers for the inclusion in this panel. I'm really honored. So Grand Challenges Canada itself is an innovation platform with a main goal to improve and save lives of women and children. We're interested in all types of innovation, including products and services innovation. The service innovation is often the one that we overlook a lot. When we think of innovation, we think of tech, but it's really how do we build more resilient systems, as a lot of the ministries of health had mentioned in their plans. How do we make sure those are built in a way that can be more resilient to pandemics or any types of changes in systems? And so that's one of the areas that we're trying to build a little bit more innovation in. But I think what we're seeing in our 12 years of existence in funding innovations and It takes such a long time for these innovations to actually come to scale and be successful. You saw two examples like Hewitele and Muso, who we funded quite early in the stage to do the ProCCM trial for Muso, for example, and Hewitele to really test and iterate on their service delivery model in Kenya, and really excited to see how far they've come, but that took 4+ years of our time to work with them. And really lots of investment and patience, I think, in order to make sure that these innovations can be successful, because these innovations don't work in a vacuum. And like Nick mentioned, there's this ecosystem wraparound approach that's really needed to ensure that innovations can be successful. So in short, I don't think that there's any specific type of innovation that's going to be a panacea for addressing child mortality in this space, but it's really making sure that there's the supportive systems in building and the focus in building resilient systems so that innovations can succeed and iterate and be adapted into new contexts.
Thank you, Carolina. I love that you've made the point that, it's not about the shiny and the sort of new innovations, but rather the systems kind of sustaining and backing that will take us and help us reach the goals. So Robert, with Unitaid's new strategy, seems to have a strong focus on child health, and we've heard a lot about Unitaid's investment in the pulse oximetry space. Can you share some of these other areas where Unitaid is planning sort of a big impact on child survival in the coming years?
Great, thank you so much for that question. So I'll build off of what the earlier panelists have said, and indeed in our new strategy, our new 5-year strategy, 2023 to 2027, we really want to build on the foundation of investments in the HIV/TB malaria space, many of which had pediatric and child access in mind. This is often a group in the population left behind, and therefore ensuring equity and ensuring that access to diagnostics and medicines and preventives for children in those major disease areas has been key. As we look at our new strategy, we are expanding this out. We entered into the childhood fever management space by over 4 years ago, putting significant investments into how we could expand access to pulse oximetry in resource-limited settings, particularly in Africa, working with partners such as PATH and Alima and others, and looking at taking existing technologies, seeing how they could be adapted, but also, to Carolina's point, leveraging and adapting approaches, primary healthcare approaches, to broadening access to that pulse oximetry. And that has been a major, intervention to accelerate better ways of triaging fever and linking these children and these infants to care. As we look at, forward-looking investments that we can build on there, I'll say that in the course of the last 2.5 years, during this pandemic, Unitaid expanded its investment footprint quite significantly to cover other areas that are really relevant, but through the lens of oxygen access. We saw during this pandemic just how critical lack of access to oxygen was, and it was the only therapeutic, to be honest, that we had for much of the pandemic, apart from corticosteroids, and how crucial it was for all populations, including children. So the investments that we programmed during the last 2 years, over almost $100 million of investments, we're looking at a number of areas that will serve all indications for oxygen, and we know the childhood population is so central to that. And they include aspects of market shaping, so working with our partners to ensure a healthier market for access to oxygen. What does that mean? It means we need to lower the prices for oxygen. We need to expand the number of suppliers. We need to make much more efficient the delivery and supply chain pathways for oxygen, particularly in resource-limited settings. And also market shaping in the sense that it's not just happening at the global level. What is really clear is that this has to be deployed and tailored at regional and more often than not country levels. And again, working with key partners such as CHAI and Partners in Health, PATH and others, we really started to crack the back of this critical and long-standing issue. And it has borne dividends. We've seen through these collective efforts in which Unitaid has been proud to play a lead role, prices reductions of 20% for liquid oxygen, 40% for cylinder-filled oxygen and for cylinders themselves. And these things are unprecedented. I mean, it took the pressure of the COVID crisis to spur us into action. It shouldn't have taken that, but anyway, that's a silver lining it did to have these dividends come about. But beyond that, we've also seen the criticality of investing in human capital, and that's technical cooperation and training, not just for frontline healthcare workers, nurses, but also biomedical engineers and others who will be so crucial to, as Nicholas said, ensuring that these massive investments in CapEx, unprecedented in the time we're talking about, don't end up being white elephants and can be sustained for many, many, many years to come. If they have the right maintenance and there's the right trained workforce to operate this oxygen generator equipment and other things, we can talk a decade, 15 years, that we could leverage these investments for child health survival, for safe pregnancy, for trauma, sepsis, etc. So it's really important. So all to say that now that we've entered into these areas, we intend to continue in these areas in our new strategy, and it's not just going to be an anomaly of COVID, and then we'll back off and not do these things moving forward.
That's great. That's very exciting to hear. Thanks for sharing. John Paul, so ministries here today are saying loud and clear that they need more flexibility from global health donors. And, you know, they've called for greater alignment of global health money with national health priorities. How does the GFF respond to that? And if there's one thing that you could ask ministries of health in return, what would that be?
Okay. Well, first I have to say, we respond to the ministry's call for greater alignment with great enthusiasm. The Global Financing Facility was set up as a country-led partnership, which places country leadership very much at the center of our business model. And what we have understood is that it is the countries that need to decide on their priorities. It is the countries that need to call for that alignment. It is the countries that have the power and the motivation to ask all of us from the donor community, from the technical assistance community, from the CSO community, to really rally around the priorities that they set. Now, the GFF is a global partnership, as I said, country-led, hosted by the World Bank, and we help the countries focus on the priority needs of women, children, and adolescents. So we're not a disease-specific institution, and we are an institution that looks at critical aspects of the lifespan. I sometimes say we're everything but geriatrics, but who knows, we may end up there eventually. But we're very, very much focused on the extremely high levels that persist of maternal, neonatal, and child mortality and morbidity, and the incredibly important issues that confront adolescents as they move into adulthood and they themselves become mothers and fathers. Now, in order to help us coordinate around this, the model of the GFF includes the creation of an investment case for maternal neonatal child health. And that investment case is a tool that allows us as the GFF, and with our special relationship with the World Bank, to leverage World Bank financing in support of the priorities that have been identified by that country. It also helps us in the partnership space to crowd in and help align resources from other areas. Just before we came into the meeting, we were talking about some of the areas in which GFF, the World Bank, and the Global Fund are working together. And we have excellent examples in Haiti, in Honduras, with Gavi as well, and also in Pakistan. And we are doing this at the demand of the country. The country is very much in the driver's seat. Now, that investment case is extremely important. And we're hearing countries say more and more often that they want to have one plan, one budget, and one report. And we are very supportive of heading in that direction. It's hard because there are many interest groups, there are many constituencies around specific disease issues, around specific age groups, and around specific challenges. But the governments can be empowered and can take the power to pull themselves together and to articulate clearly to the rest of us how we can contribute to their priorities. One of the things I think that we're very proud of is that we have worked together with government leaders, and particularly Minister Leah from the Ministry of Health in Ethiopia, who leads the GFF Country Alignment Working Group, where this is a group of ministerial level folks that get together periodically and help articulate to the Global Financing Facility and to our investors group and our donor board what the priorities of the countries are and how the countries can take the lead. And we very much would like to see more of that. So if there's one thing that I would ask the countries here to do, is to speak clearly, speak often, and speak together about what your priorities are and why we need to align to reduce the inefficiencies in our current aid architecture that result in the dollars buying pennies worth of services. Thank you.
That is very clear and helpful advice. Thank you, John Paul. Nick, I'm going to come back to you. So many countries have really struggled to finance pneumonia and diarrhea treatments for sick children. While malaria and HIV/AIDS, as we know, has been relatively well covered by the Global Fund, I would say this imbalance has really compromised the integrated treatment of children, childhood illness. So the Global Fund recently announced a new approach that will likely transform the integrated management of childhood illness. Can you describe it and help us understand what that looks like?
Absolutely, and thanks for bringing that up. It was actually mentioned in the previous panel, so they took the wind out of my sails to say, but I can go into some of the details. The new approach is actually not new, but it comes from this whole approach of integrated management of childhood fever, actually, because children don't come in with malaria, they come in with fever. And they come in, for the Global Fund, it's immensely critical to ensure that the ACTs, the malaria management that's being funded by our grants, is appropriately used, is rationally used, and it made sense for us to expand the possibilities for countries to provide the entire package of services at the community level. And so this relates specifically to providing an entry point for countries within their grants for malaria, or say within health systems for the community health platform, to include amoxicillin for the treatment of pneumonia and other infectious diseases that under fives can present with. Amoxicillin is not just for pneumonia, but and also for ORS and zinc, that is part of the WHO guideline for acute diarrheal diseases. So the approach in the new cycle would be for countries to submit funding requests for the community health platform, fully covered for all the other essential components for the health system that needs to capacitate the community health workforce, and over and above that, use the flexibility to include amoxicillin and ORS and zinc. I think one of the caveats about that is to ensure that the country has a way of monitoring antibiotic resistance. So it's all fine to be able to provide amoxicillin into the community, but as you heard from the previous panel, we need to ensure that it's working, obviously, right? So make sure that you have the necessary checks and balances. You could even include antimicrobial resistance within the lab component of your health system's requests within the Global Fund grant. So that's kind of how it works. But I also wanted to add on one more piece before I close. I know we're running out of time. But I wanted to shout out to Pat and Shai, who is doing a lot of work on pulse oximeters. And I feel like even though one of the pieces that is part of the wraparound that I was talking about in the last question is to ensure that the use and the demand of oxygen is adequately taken care of, which not only means training of providers, but who have never had oxygen, training providers, but also giving them the equipment to be able to diagnose hypoxia. How do you diagnose you can't do it clinically. So I think we need to be able to quantify the pulse oximeters, and I wanted to shout out to Pat and Chai for doing that work, and we should, for ministries, please look to your partners within your country landscape and utilize some of the work that they're doing to bring into your funding request to the Global Fund. So the pulse oximeters will fit into your health systems funding request, and the amoxicillin and zinc will fit into your community health platform request. So I'll stop that. But feel free to reach out to us anytime for questions.
Yeah, I think we cannot emphasize enough sort of the critical role of pulse oximeters. A simple device, yet very powerful in transforming the outcomes for our children. Carolina, so back to you. Many countries are looking to strengthen their own national healthcare and innovation networks. And there's several grand challenges groups out there who are active. How would you advise sort of governments in this room who want to support local healthcare innovations?
Yeah, so talk to us, like if there's grand challenges in your country, feel free to reach out to me or to those representatives, and I'm happy we can facilitate those conversations. But we're also open just to talking to, I think it's really great if you can also surface some demands, like a little bit like what John Paul was saying. We really want to hear from what the ministries of health and really needs. We're currently working on a project right now in Ghana where we're actually co-creating an RFP with the government. So we went through a whole exercise where we determined what were the maternal newborn child health needs and narrowed it down to 4 focus areas. And that was a 3-day workshop with all members of key focal areas within Ghana, as well as looping in the innovation community. And I think that's the crucial part, is bridging the gap between the innovator community to the Ministry of Health, because oftentimes there's a gap in understanding of what the innovation ecosystem could actually offer to the Ministry of Health. So I think that was a really enlightening process for us to see, and for the ministry to see, that there actually wasn't actually very clear understanding that there was a lot of innovation in the country itself. So trying to build those connections and be more open to an innovation ecosystem, talking to innovator hubs, talking to key focal people who lead innovation in certain departments, I think would be really a great start to helping bridge that gap.
Thank you for that great advice. I hope the ministries of health and all our partners here today would sort of reach out to the GCC in-country folks on that. And John Paul, I want to circle back to you again. So the GFF enables countries to leverage World Bank money to accelerate child survival, so that countries can really finance the strong health systems to reduce maternal and child deaths. It's a lot of money. So how can you make sure that it delivers the results that it intends to, and doesn't displace domestic investments?
Okay, thank you. It is a lot of money, but it's not enough money. And that is one of the reasons why the issue of alignment, I think, continues to resonate with me. One of the things I think that we need to understand is that coming out of the COVID pandemic, that the reality is with domestic resources, that the projections that we're seeing do not indicate that we're going to have a big jump in the availability of domestic resources in the health sector. And as we all know, many of those resources go to keeping people employed, keeping paychecks moving, and so on and so forth. So although the GFF has an entire effort in our health financing area to increase domestic resource mobilization and utilization, we also are dealing with the importance of being able to complement that with effective external investment. And that's where the leveraging with the World Bank comes in. And we have been quite successful. We provide grant funds. So when funds go from the GFF to a country, they belong to the country, they go on budget, and they never have to be repaid. They're a grant, they belong to the country, they are spent as part of their budget. Now, the leveraged funds that come from the World Bank are usually in the form of IDA, and these are credits which are in fact loans of a sort. They may not have an interest rate associated with them, but the principal does have to be repaid. And so the government is making quite a domestic commitment when they accept to take IDA loans. The grant funding from the World Bank, from the GFF, sweetens that pot. It makes it more acceptable to the country to accept the lending conditions of the World Bank. And it mobilizes resources which, again, are on budget and are used according to the plans and that are put in place by the country. Now, the accountability comes across those plans. These are very, very, very participatorily developed. The World Bank, the GFF, and the country and the stakeholders sit down to develop the lending operations that are grant and credit financed. And we have frequent and periodic check-ins to make sure that the projects are being implemented on time, the disbursements are being made, that the results are being achieved. And we move more and more towards results-based achievement. One of the things that is very useful about the arrangement we have with the World Bank is the World Bank is not a health organization. The World Bank is a development organization. And this provides us the opportunity to also work cross-sectorally for those issues that require cross-sectoral solutions. One of which that's been coming up in the last day or so has been the issue of nutrition, which is an underlying condition that affects mortality from pneumonia, from malaria, from many other things. And effective solutions to undernutrition, especially chronic undernutrition, are very multi-sectoral in terms of what is required. And so with our nutrition programming, we're able to make investments in countries, not only through the Ministry of Health, but through Ministry of Gender, Ministry of Local Government, Ministry of Education, and Ministry of Social Protection, for example. And so what we're trying to do is make sure that we can address health problems, not only through investments that are made in the health sector, but investments that are made in development across sectors for solutions that require multi-sectoral solutions. I think I'll stop there. I know we have some time constraints, but I could go on for quite a while about this issue. Given time, and happy to do that with people in the hallway afterward. Thank you.
That sounds great. And thank you for bringing across sort of this common theme of multi-sectoral approach that we've been hearing throughout the forum. Okay, so Robert, I'll turn to you. The last question for the day. We have heard ministries call for more coordination from global health agencies. In the way that they finance child survival, and UNITAID leads the Oxygen Emergency Task Force, which we've all benefited from, and thank you to you and the team for the great coordination, and brought us all together during the COVID pandemic. So what have you learned about how to coordinate the activities of so many agencies that would be helpful for ministries of health here today? And what is the future of the task force?
Great, thank you for that question. So I think one really important takeaway from how the Global Oxygen Emergency Task Force was formed in the crucible of this pandemic in February 2021 was that it built, the coalition was built on the back of the mandates and the strategies and the efforts of many partners who were already vested in ensuring equitable, sustainable, affordable oxygen access, amplified and focused during the context of the pandemic. So it wasn't so much a difficulty for UNITAID and at that time Wellcome to issue the call to partners to come together and align behind a common approach to accelerating access during the COVID pandemic, for COVID first and foremost, but then for the systems that were still continuing to serve children, women, and others during the pandemic. And therefore, getting those partners to come on board was not the challenge. I think the challenge was really about how we could very openly and honestly put forward our respective comparative advantages, our respective strengths, our respective mandates, and see where they could fit within a common response strategy. And essentially, very quickly, we came up with 4 or 5 critical pillars for that response around which we could coordinate ourselves. Central to that was the fact that we needed to understand better the needs in each country, which are unique during COVID and more broadly. So those needs assessments, we came around and identified what would be the best way to work with governments and partner with them on the ground to assess those needs very rapidly during COVID, and then translate those needs into rational funding propositions, right? And that was really critical in securing the impressive figure on financing that Nicholas mentioned. Nearly $600 million from this COVID-19 response mechanism was secured in a matter of 18 months. That didn't just happen out of thin air. There were partners working with governments on the ground to baseline the needs, develop the proposals, and then to get them to the Global Fund. And then also to partners such as UNICEF and UNITAID and USAID and others who were also crowding in financing to support this. So the needs pillar was key. Then the linkage to financing pillar was very key as well. And you had natural partners who obviously could stand in and take a lead there. Then, of course, we needed to ensure coordinated and effective procurement and delivery. And again, identifying partners who could step forward, indicate how they could do it and how we could align on that. And then link to that market shaping, right? Who were the partners who could come to the table based on clear, deep experience on how they did that with other health commodities, therapeutics and otherwise, and bring that to the table. And other partners, INGOs and others who are central to that equation. And then 2 others which were really key was monitoring and evaluation, meaning we mobilize over $1 billion, we have to account for it. We have to demonstrate based on some aligned KPIs, what is the impact we're delivering, economic and public health. And it's not easy, but that was really critical, and WHO stepped in to lead and coordinate that aspect. And then demand generation and advocacy. And partners like the Every Breath Counts Coalition and their wide coalition of partners were so central in ensuring that governments had this at the top of their agenda, that they were putting in proposals to the Global Fund and others. And that this was not something that was neglected, alongside vaccines and other interventions at the time. So there are many lessons on what can work, but it did require partners, and I hope this wasn't just because of the pandemic, to put aside, territoriality and the like and say we have to come together, align on who can lead what and coordinate on those dimensions. So that's really, really key. And you've heard that over $1 billion was mobilized, $600 million from the Global Fund, another $400 million across USAID, UNITAID, UNICEF, WHO, ELMA, Gates, and so on. Really critical. And as was said here, that is an impressive figure, but we need more. But most importantly, we have to consolidate the gains and the impact of that money. We can't squander that opportunity. It would not be credible to go and chase more money to fill even larger gaps for childhood survival and otherwise if we can't ensure that spend is sustained. So that is really a really critical lesson moving forward. Now, we can't allow these efforts to simply be an anomaly of COVID, right? The Oxygen Task Force has now come to a close as the ACT-A, the Access to COVID Accelerator, has concluded. But your question was, what next? And so you've asked me to speak last, so I'm going to end this panel with a bang. And we're going to announce a commitment, because this forum is also about concrete commitments. And so I'm just going to ask Nicholas from the Global Fund and Africa CDC, represented by Taj, to come up onto the stage so that we can make this commitment together. PAHO is not here, the Pan American Health Organization. Otherwise, I would have also invited them up to the stage, because you'll see why in a minute these 4 agencies are collectively making this commitment announcement. So come over, Taj. We're just going to go to the front of the stage so I can answer the question with a commitment. So come over here. And those of you who have nodded off, wake up. You need to hear this. So as I said earlier, all these efforts and the hundreds of millions of dollars still in play cannot not deliver impact. They must. And therefore, as the Oxygen Emergency Task Force closes, we are committing to the launch of a brand new Global Oxygen Alliance, which will be launched in 1 month's time on the 24th of May on the sidelines of the World Health Assembly in Geneva. The Global Oxygen Alliance is going to be co-led by 4 agencies, the Global Fund and UNITAID, as well as Africa CDC and PAHO. It's going to have a secretariat of UNITAID and WHO. And the task force, the oxygen task force that was so effective during COVID, will be folded into this alliance. But not just that, we'll expand its membership. We've done a massive consultation over the last 3-4 months with over 200 stakeholders, and there was consensus that we should bring in country voices. So initially, we'll bring in 6 countries, 6 LMICs who are co-sponsors of the WHO resolution on oxygen that we hope is tabled and adopted in May. We will also bring in the voices of communities and civil society. So there'll be 2 seats for communities as well as NGOs, and additional bilateral donors to those who are part of the task force as well. On top of that, without reinventing the wheel, the Global Alliance will leverage the Oxygen Access Collaborators Network, which is a really great network set up by the Lancet Global Health Commission on medical oxygen security. And that's a wide network of partners, global, regional, country, that can be a sounding board and a ground truthing group of experts and partners who can help the Alliance move forward. We've already established some objectives for the Alliance. The first is going to be to ensure we consolidate the gains and the current investments. We must make those work. We must show impact for those. The second will be to build off the really important country roadmaps for oxygen, not necessarily vertical roadmap, but roadmaps that are part of often another road mapping response in countries, that each country has one, which basically shows what's your oxygen strategy moving forward as a part of your broader strategies in country. Is it costed? And how can we ensure that then moving forward, it is the financing that is mobilized or in play is aligned with that strategy? So that road mapping objective will be really key. And WHO will convene a meeting in Q3 this year with multiple member states on country roadmaps, showing archetypes of those that have been developed, that look good, that work, and then helping countries to further develop them if they haven't already. The third pillar is procurement, supply, and market shaping. We still need to optimize all the CapEx and other investments in play, and then ensure that where funds can be reprogrammed to cover soft human capital training, biomedical engineer training and onboarding, we also factor that in, and we don't only procure equipment. And then 2 other areas will remain from the previous task force: our KPI and monitoring evaluation work stream, to again ensure we are accountable behind agreed and aligned KPIs on delivering impact as an alliance. And then lastly, advocacy and resource mobilization will remain central to that. So I'll leave it at that, but say it's real. It's going to be launched in a month's time. There are many partners beyond ours who will be involved, who have been part of the task force in this room and otherwise. And we really appreciate that they've all come behind to say that this is something we must continue and continue to deliver on for childhood survival, but also for all the indications we know oxygen is so key for. So thank you.
Thank you. This is fantastic news, and thank you for sharing with us.
Thank you.
Okay, we have a video to play from Dr. Gabriela Jesus. She'll tell us about EU's sort of new global health policy and what it means for child survival. So let's take a look.
Ladies and gentlemen, it is a pleasure for me to address this important forum today. Unfortunately, I cannot be with you physically. Pneumonia remains a major cause of death of children in low and middle-income countries, and addressing it must remain a high priority for national and global health agendas. The European Union has recently adopted a new strategy for global health that is currently being debated by EU27 member states. The strategy prioritizes the strengthening of health systems in low and middle-income countries, in particular focusing on strengthening primary health care, as well as access to innovative vaccines, medicines, and diagnostics that should be developed and used and equitably accessible in low and middle-income countries. Thank you.
All right, with a few seconds remaining, or actually time is up, but to say thank you very much to our panelists. You've given us very strong, clear messages around sort of your prioritization for financing. And very quickly before I close off, I'd like to just add that and call on all the funders and ministries to remember how vulnerable our children are, and that we should, and you know, let's face it, children are often casualties when resources are tight, and they cannot speak up for themselves. So it's up to us all in this room to prioritize them and together fund the pathways and mechanisms that can maximize their health outcomes. Thank you very much.
Thank you.
And a big thank you to Jinji and her panel, and to the surprise commitment announcement that was made. We're going to stop for a very short break. If I can remind you, if you haven't signed the declaration, now is the time to sign it. But I really do want to ask everyone to be back in their seats at 25 past, because we have a couple of special guests that will be joining us for the final sessions. So if you can take a 20-minute break now, please be back in your seats at 25 past, and we're almost there. Thank you. Okay. And if the people who are still standing could take their seats as quickly as possible, that would be great. Thank you all for coming back so promptly. It's very much appreciated. We've been talking about some of the issues of financing. We're going to go into a panel now that's going to look at the role of the private sector in pneumonia control. And we have some very special guests in this panel. But let me introduce the moderator, Ms. Monica Bail, and she will introduce her 4 panelists. Thank you very much, Monica.
¿Qué contiene una vacuna contra la neumonía? Para él, la fórmula es la suma de una oportunidad, sueños y sonrisas. Para la Alianza para la Vacunación Infantil, una vacuna también se compone de velar por la sanidad y el crecimiento de los niños, incrementar el desarrollo de los menores y mejorar su educación, el descenso de los costes sanitarios y el aumento de una población más sana y el fortalecimiento de las economías. Sumando todo ello, salvamos vidas. En colaboración con Gavi de Vaccine Alliance, trabajamos desde 2008 para que los niños menores de 5 años de América Latina y África tengan acceso a vacunas seguras y asequibles. Juntos, hemos ayudado a vacunar a más de 9 millones de niños. Nuestra lucha es hoy más necesaria que nunca para evitar que la crisis de la COVID-19 tenga más efectos colaterales, contribuyendo a proteger a los niños de las comunidades más vulnerables de enfermedades que pueden prevenirse con vacunas. Tú puedes ayudar a que siga creciendo la generación del futuro. Una generación que tendrá una vida más larga, más sana y productiva. ¿Quieres formar parte de nuestra fórmula? Ayúdanos a sumar vidas.
Welcome to this special session, the role of the private sector in pneumonia control, taking as a model the Business Alliance for Child Vaccination launched by La Caixa Foundation in 2008. Private sector can be a key actor in the fight against child mortality. There are a lot of examples of foundations that have promoted different initiatives and partnerships to pilot projects to improve the prevention, detection and treatment of pneumonia. We are going to discuss on how private sector can be a model of doing business responsibly where the most vulnerable will take advantage, in this case, in the fight against pneumonia. I would like to begin by welcoming Her Royal Highness, the Infanta Cristina of Spain, Director of International Area in La Caixa Foundation and driver of this successful alliance, who will explain to us this very rewarding and long partnership with Gavi, the Vaccine Alliance. 15 years of the Alliance for Child Vaccination, launch, challenger, results, etc. Why is this initiative the priority for La Caixa Foundation?
Thank you very much, Monica, and thank you all for being here this afternoon in this very special session for us. It is very difficult to summarize in just a few minutes everything that has happened along these 15 years in what I consider the most exciting and long-standing partnership between La Caixa and Gavi, the Vaccine Alliance. It is really very, very special for us. To give you some context, it was during a field trip to Mozambique back in 2005, in January 2005, when we first heard about Gavi. Our delegation had an opportunity and the privilege to hold a meeting with Graça Machel, then chair of the Gavi Fund, and Nelson Mandela, the founder of Gavi Initiative, together with the Bill and Melinda Gates Foundation. That meeting was the seed for organizing, in a short span of time, the first Gavi Symposium in Spain in March 2005, led by Dr. Pedro Alonso, who's here between us, a key figure in the global fight of malaria, as you probably all know. It is actually Pedro who introduced me and my team to Gavi. The symposium gathered health agents from the private and the public sector and turned out to be crucial to achieve, for example, the commitment of the Spanish government to Gavi. We can say that the partnership between Gavi and La Caixa had already begun. In February 2008, the president of La Caixa and the general manager of La Caixa Foundation traveled to visit in Mozambique Gavi's work in the field, a field trip that turned out to be key to support Gavi's mission. La Caixa Foundation donated 4 million euros to Gavi for child vaccination, making La Caixa the first private sector partner of Gavi in Europe. We then went one step further and launched, together with Gavi, the Vaccine Alliance, the Business Alliance for Vaccine, for child vaccination, an initiative to encourage the participation of Spanish companies in the fight against child mortality. And not only that, we also decided to extend the campaign to its thousands of employees and clients of the financial institution, CaixaBank, to give them the opportunity to contribute to child vaccination. The Barcelona Institute for Global Health joined the Business Alliance as a strategic partner in 2014, bringing its scientific and academic expertise to the project. Since 2011, within the matching fund scheme, all donations are matched by La Caixa Foundation. And what's more, the Bill and Melinda Gates Foundation matches again that figure, meaning that for each €1 donated by a company or a private donor, €4 arrive to Gavi, quadrupling the efforts on our common fight against child mortality. Amount invested in fighting pneumonia. Today, 15 years later, La Caixa Foundation is still committed to Gavi's mission. At the foundation, we feel very proud for every single contribution, be it from a company or from an employee or from an individual. And we also give enormous value to the sensitization, a factor which is also very important in this partnership. And the results of this partnership have been excellent. Over 43 million euros have been raised for the Alliance to contribute to the vaccination of almost 9 million children. Since 2013, all contributions have gone to the pneumococcal vaccine in Mozambique and recently to Ethiopia as well. But we need to continue the hard work and persevere in order to reach even more children and achieve universal immunization, a right for all children. And quoting Graça Machel's kind words at the launch of the Business Alliance back in Barcelona 15 years ago, this is a magnificent lesson in how to be leaders in business and in social responsibility.
Thank you very much for your explanation and for being the founder of this collaboration. Thank you so much. Welcome, Mr. Guillaume Grosso, Director of Sovereign and Private Sector Engagement, Donor Relations and Campaigns in Gavi, the Vaccine Alliance. How does Gavi value this long-term partnership with La Caixa Foundation, and what's next for the partnership from Gavi's perspective?
Thank you very much, Monica, and thank you very much, Doña Cristina, for the incredible support over the year. And I want to turn to all the people here in this audience for your support. And I see many faces, whether you are wearing a jacket or not. I know you are there since the beginning. And that's a great pleasure to see you again here in Caixa Forum, which is very special for us. So yes, indeed, it's been 15 years together, and I'm really grateful for the opportunity to celebrate this very special anniversary since 2008 with the Alliance for Child Vaccination and with all of you. Because in fact, as you mentioned, Doña Cristina, this partnership is very special to us in many ways, the first of which being that this was the very first private sector partnership in 2008 with Gavi, the Vaccine Alliance. We define ourselves as a public-private partnership. We started, of course, partnering with a lot of different actors and players, but the very first time we had a private sector partner long-standing was in 2008, and that opened up a number of other and new opportunities. We value this partnership because, of course, that has helped us first to increase massively the immunization of pneumonia, particularly in Mozambique and Ethiopia. That has been, of course, a big difference for tens of thousands of people, millions of people that could benefit from this vaccine. We can talk about the big numbers. The big numbers are amazing if you look at the dollar value, because together with your help, with the help of your customers, the help of your employees, the help of the businesses that are part of the Alliance, and the help of the foundation, we managed to bring together $87 million. That's a lot of money. But money doesn't speak as much as lives saved. Doesn't speak as much as people who were addressed that could benefit from the vaccine with this money. And today, we have done more than 9 million vaccinations just with this program, 6.5 million vaccinations just for pneumonia. That's an amazing result that would not have been possible had it not been for this partnership. So, you know, we can talk about partnerships, and of course, this wouldn't be possible without governments. You know, it's a public-private, so the government of Spain has been amazing. They've been a pioneer since the beginning of Gavi, actually, when we started, for instance, the vaccine bonds in 2006. The Spanish government was one of the founding fathers or mothers of this partnership. Thanks to La Caixa, the partners, the Gates Foundation, but more than a partnership, I see that as a family. Because what we are doing together is coming together and addressing the issues as they arise, talking through them and finding new solutions together. And I want to say that when I look at this partnership that we've developed together, above and beyond the lives we could save on the ground, what it has brought here in the public debate in Spain is the knowledge, the acknowledgement that we have an issue with pneumonia that we need to sort out. When you push the door of a branch of any Caixa bank in Spain, you will be reminded that pneumonia may not be in front of your eyes, but should be close to your heart. And that, I think, is extraordinarily important. We need to keep pneumonia on top of this agenda, and that is a benefit of this partnership. Now, I want to turn to the future, because, you know, 15 years behind us, and I hope, Doña Cristina, I hope Joe Sorrell from the Gates Foundation, that we will be able to say 15 years ahead of us, because we shouldn't stop there. Over the last 2 days together, we know that we can and we must beat pneumonia, and I think we can do it together with a public-private partnership. We need investments in immunization. We need money to buy vaccines. We also need expertise to solve the challenges. We need innovation from the private sector. We need all of this to come together. And in fact, and let me finish with that, we will be back in Spain very soon. You might have heard of it on the 13th, 14th, and 15th of June, hosted by the Prime Minister of Spain, hosted by the Foreign Minister of Spain. We will host here our global immunization results, vaccine results conference. That's Gavi's midterm review. That's the moment when we press pause. We look at the road so far. We take stock of what we've done, but we also look at the road ahead and how we can double down and accelerate on our efforts. And I welcome everyone and our private sector partners in this room to join the fight, to join La Caixa, to duplicate, replicate, amplify this model because it works and we need more of it. Thank you very much.
Thank you very much, and we hope to continue our collaboration very closely. My next question is for Joe Serrell, Managing Director of Europe, the Middle East and East Asia in Bill and Melinda Gates Foundation. Joe, as a representative of one of the largest philanthropic organizations investing in global health, can you firstly share with us why you invest in Gavi and this private sector partnership with La Caixa Foundation? And secondly, do you think others could reproduce this model given official development assistance is no longer growing as it has in the past?
Yeah, well, thanks. And I also want to really extend my appreciation to my fellow panelists, starting with Infantina, Christina, and also to all of you who make the effort to travel here. I guess to your first question on the role of philanthropy, the philanthropy does have a unique position in that we can take, in many cases, investments that for various reasons may not be appropriate for governments or for the private sector. We can, and we're charged by Bill and Melinda, by Warren Buffett, to make sure that we're taking high-risk investments in big ticket items, things that really could help unlock things like how to prevent more childhood deaths in the future. And we can afford to take long-term bets as well, meaning that we don't have to look to outcomes on some of these investments in the next election cycle or the next quarterly review with our shareholders. So philanthropy has a very unique role, and we like to take advantage of what philanthropy has to offer. And one of those other features is the ability to draw in other partners from different sectors and to think about what are the ways that we can partner to combine the expertise that each of us brings to try to solve some of the big challenges that you've heard and you've been discussing over the last day or so here. For us, childhood illness and under 5 child mortality in particular goes to the heart of everything we do. We get up every day thinking about how we can really solve the inequity that continues to exist with under 5 child mortality. And so for us, vaccines is a natural place to have started. And Bill and Melinda really saw firsthand the effect of vaccines, the power it can have when you have more equitable access to vaccines. Rotavirus was one of the first areas that they looked at, and they saw this incredible inequity, 1 million or so deaths plus that were happening in places that didn't have access to the kinds of vaccines but do today. And the same kinds of illnesses not having nearly those kinds of effects on the health of children living in richer countries. So it's really getting at that inequity and really thinking about how vaccines could play a role. And so Gavi really for us was, I'd say today, probably the best investment that the foundation has ever made. It's really catalyzed a lot of the financing that we need. It's really signaled to industry that if you build it, there's a market to buy it. It's really helped to think about how we can get better at improving on delivery and procurement and the things that have been under discussion here. So we're incredibly proud of all that's been achieved. Nearly 1 billion children vaccinated, 16.2 million deaths averted. And the good news is that since the start of the Gates Foundation in the year 2000, we've been able to cut by half the number of children who live to see their 5th birthday. And it's still too many deaths that we have, and the inequity is still very apparent. But I think we should all take some pride in the fact that when we marshal the resources, the political commitment, and the ability to deliver on the ground, we can achieve remarkable results. I think it gets a little to the partnership with La Caixa and something that we're incredibly proud of. 15 años, 15 years that we embarked on this, and it's been an amazing partnership. We've both grown, I think, on all sides, from the Gavi side, from the Gates Foundation, working with La Caixa. La Caixa's ability to bring in, with the Child Vaccine Alliance, many other partners, and really tell the story about why vaccines are an incredible investment in the health, the productivity of future generations has been something that has really been outstanding. COVID has only reminded us just the importance of this. I like to think that if we hadn't created that partnership 15 years ago, it's exactly the kind of thing that we would need to create today. Fortunately, there were leaders 15 years ago who really saw the importance of working together. And so, I think the other thing that for us is a really important thing is that the partnership is a reminder about the success. I actually look back when I was researching for this panel, a press release that we had done, I think it was about 10 years ago. And there, in the press release, it was saying that pneumococcus was still killing 1.5 million children every year. Pneumonia was, and that number's been reduced to 700,000 or so deaths. Again, still too many, but again, it's a good reminder for us. These are vaccines not just to help children, but they're vaccines against cynicism. People who think that you can't make progress, that money gets wasted, you never know really what happens. It's a great reminder, and I think the power of this partnership is to provide some of that visibility to people, to say that when you do commit, good things will happen. So it's something that we're deeply proud of. It's a way for clients, for customers, for some of our other partners who think, why would I invest in this thing called pneumonia? I don't know anything about it. It's a disease that my children get vaccinated for. I don't know where to start. What good would my money do in the first place? But you've seen and heard Infanta Cristina talking about the leverage. 4-to-1 leverage gives you the power to be part of that solution, but also be part with thousands of other people, clients, customers who also really want to stand up for the health of the world's children. So it's a really important thing, and I think we're deeply proud of the partnership, and hopefully both at the midterm review coming up, but as Gavi looks ahead to 2025 and its replenishment, we'll be able to crowd in even more private sector partnerships and be able to think about other companies and organizations that can be part of this great story. So thanks.
Thank you very much. Thank you so much. And moving on, Mr. Alfonso Jimenez, Chief Research and Innovation Officer in GoFit Lab. It's a sponsor of Gavi. Why is the commitment of companies to improve child mortality so critical, and what are the key elements that can convince a company to decide to join and collaborate in the Alliance for Child Vaccination?
Thank you very much. Good afternoon to everybody. We are especially happy and excited this afternoon here, no? Because this small project that started with a small amount of money a few years ago gave to a really small company focusing in active living, in preventing non-communicable disease, those related with your behavior, the ability to feel super powerful. Because we are a super powerful company. Because we invest 1 and we deliver 4, thanks to your commitment, guys. So it's not our merit, it's the merit of the idea, of this fantastic idea that is able to get any one of us able to make a significant impact. And I think that is relevant as well about the role of these sustainable and responsible businesses that are coming, especially after the pandemic. This perception of companies is fantastic, that we deliver money for our shareholders, provide value for our customers, etc. But for us it's critical because GoFit is defined not as a gyms company, we are a happiness company. Our mantra is happiness is trainable as well. You can do a lot to improve your life, but you can do a lot to improve the life of the others. And this is the interesting point here, That is not about that I'm taking care of myself, I'm eating well, taking care of my kids. Our commitment is represented by kids in GoFit are not paying anything up to 16 years old. And with this strategic decision, we solve the gender gap between men and women doing exercise or physical activity in Spain. In just one decision. Now imagine a company that is serving 250,000 of members, that is putting just one small amount of money that is multiplied by 4, because there is an ecosystem that recognizes that there is the opportunity and the responsibility to do business in a different way. And I think that this is a clear example of what is the power of this. And I think that is something that should be immediately replicated. There is no excuse. It's not acceptable that pneumococcus is killing 750,000 kids today. Come on, guys. That we have 25% of childhood in this country at risk of poverty. It's incredible. So it's arriving to the level of the individual decision. So we have to be much more demanding in our companies, not just in our institutions. We are really good in democracies to challenge governments and demand rights, but there is an opportunity for any single company in this country. 3.4 million companies formally registered, only 6,000 involved in this fantastic project. I think, guys, that we have room to improve. Now extrapolate this at global level, and I think that for a company like us, this is a super powerful message. And when we tell this to our members, our customers, they are recognizing our commitment with society. They are giving credibility to our ability to transform society. And there is no better way to spend any single euro in GoFit than in this project. So thank you very much and congratulations, guys. Very well done.
Thank you. Thank you very much for your time and for your testimony. It's important for us. And we hope to be able to transmit this message to obtain more collaborators for the Alliance. And now, I'd like to take a moment to explain very shortly, as a representative of CaixaBank, how business banking can help spread this alliance to the whole Spanish business networking. Business banking is an area in CaixaBank that manages the business of companies with a turnover of 500 million euros. We have more than 200 centers in Spain and more than 2,200 employees specialized in advising companies. Each client is assigned a specialized manager who is the main responsible for compliance with the management and service model defined for business banking. The Alliance for Child Vaccination has been with us since the birth of business banking in 2008. This project is part of our DNA, and this is how we transmit it to our clients. In commercial visits, in our events, we always refer to this alliance because it has a great impact worldwide and allows us, in addition to being the bank of many companies, to also be their benchmark in terms of corporate social responsibility. This is the reason why the program is part of our portfolio of products and services. And how do we promote the program among our managers? We ask directors to get at least one donation from one of the companies they manage. Each of the managers has a client base of between 150 and 300 clients, which depends on the size of the company. During the year, we give awards to the best managers who achieve greater numbers of donations. You can imagine the healthy competition that exists between centers and managers. All of them want to be top ranking. The award is to go to Gavi headquarters in Geneva. This experience changes the way of living and explaining this project by the winners. And they always ask us to take a visit to see firsthand how the program is carried out in Mozambique or Ethiopia. In our visits, in our business meetings with clients, when we have finished our financial conversation, we say, okay, now let's talk about what's really important. And in this moment, especially that moment, there is a magical change in the conversation and the relationship with the company reaches another dimension. When we get home, when we are with our friends, with our family, we talk about our work, we talk about Gavi. It is the part in which we feel the greatest sense of achievement and impact at a social level. And I'm sure that our clients have the same feeling, and they are very happy that we make them part of this kind of project. Employees who are part of companies that contribute to programs like Gavi feel much more identified with the company, and this has a direct impact on their results. We must value this project and its impact worldwide and make companies aware of the importance of contributing and giving back to society what it gives us. It is our responsibility to offer the companies the opportunity to be in this alliance. It's not a favor, it's a debt. Thanks to the interventions of the speakers and the vision of what was discussed, I think it's safe to say that thanks to having done things well and to perseverance and transparency of these programs, we have achieved a lot of donations, and we have managed to vaccine more than 9 million children, contributing to the reduction of infant mortality. This is an example of how public-private collaboration makes sense and can be extrapolated to other areas of improvement. And above all, stress the importance of continuing to advance in the field of vaccination that helps preserve the fundamental right to life. We are celebrating our 15th birthday, and this has been made possible by a long-term commitment to partnership from the private sector, which is essential to achieve goals that are long-term and lasting over time. Thank you very much for your attention, and enjoy the closing part of the second Global Forum on Childhood Pneumonia. Thank you so much.
Thank you very much for that panel. You know, sometimes as activists, whether it's health activists or social activists, we're so busy climbing mountains that we don't realize when we've done something good. And we need to celebrate the successes as well as pointing out our challenges and our failures. And 9 million vaccinations, that is something to celebrate. So thank you to the people who really made that possible. And let's look to the next several million more. We now are going to have an intervention, and I'm really delighted to introduce Dr. Naveen Thacker, the president of the International Pediatric Association. Dr. Thacker, thank you.
Good afternoon, and thanks for the invitation. 39 years back, I joined Department of Pediatrics, and in last 39 years, I have seen hundreds or maybe thousands of cases of pneumonia, pyogenic meningitis, and many other infectious diseases. I don't see pyogenic meningitis anymore. So in my lifetime, I have seen the power of vaccines, how the Hib disappeared, how pyogenic pneumococcal gone down, but pneumonia I continue to see. And pneumonia is still a very much unfinished agenda. And thank you very much for organizing this forum on pneumonia. And today, I am here as president of International Pediatric Association, which is a 112 years old umbrella organization of all the pediatricians, 164 member societies from more than 150 countries representing 1 million pediatricians. And something is missing in slides, but it's okay. So the beauty is that IPA is the only umbrella organization of pediatricians around the world, and everyone is very happy to work that umbrella organization. There are no parallel societies of pediatrics. everybody from small to big society is member of IPA. And our guiding principles, which I wanted to show, but it's not coming in the slide, is based on collaboration and partnership, which I want to emphasize here, and working together. Our focus is very much on women, youth, and children in humanitarian emergencies. So IPA theme for the 23-25 is reaching every child. And how do we reach every child? We cannot reach directly to the child. We work through our member societies, and member societies pediatricians are members. So what we are planning that we have 150 plus countries, but we should have country pediatric society represented in IPA, and we are going to create by invitation a unique ID for 1 million pediatrician, and I am happy to announce here that we have extended that to the pediatric workforce, because we realize other healthcare workers are also important. So they will be all invited to join IPA, and that is what I call IPA at the speed of thought. So once with a one click, we can reach to all of them. We are planning to have social media reach, 1 million or more, at least one IPA program. And we did our strategic planning, IPA strategic planning in 21-22, and with a very rigorous process identified, with the help of consultant, identified these 6 strategic priorities. I want you to focus on one, which is for children. Our priority will be work to improve the health and well-being of children across the world by highlighting their needs, providing expert guidance on addressing them, and increasing the visibility. And this is everything which requires attention of the children, their needs. We want that to increase the visibility of that. Second thing is very much on pediatric workforce, empower pediatric workforce to promote and implement evidence-based scientific and global health standards for the quality care. And third, as I said, we cannot reach directly to the children, and we want to reach to the pediatric workforce, and that is why we need to strengthen and empower active pediatric society in every country. I was happy to meet many people who told me that this is what we require, that we require a very active pediatric society in every country. And as I said, we very much are there for the collaboration and partnership with other healthcare professionals, partner organizations working for children health and well-being. So anyone who is working for child health, we are very much open to the partnership. Last two, I will not go into the detail. So we just had a IPA Congress in India, and on 20th of February 23 in Gandhinagar, in front of the chief guest, the chief minister of Gujarat, we released this call to action and commitment, because there are always many call to action, but we thought this will be a good time to get a commitment from 100 plus countries, and out of that 40 countries from Africa who participated, and many of them are here. We took this commitment from them on, and they were administered an oath to commit to this. And so this is what why we felt the need to have a call to action and commitment, because, and I'm just highlighting, and this is already covered, so I will not go into the details, but this is why it is necessary. We know 5 million children died during turning 5 years old. 25 million children under-vaccinated now. 18 million now, million vulnerable zero-dose children. 1 in 3 children exposed to dangerous level of lead. And all this already very well covered here. We also know 80% of preventable child deaths fall into 2 regions, and that is why I said we have a lot of countries from these regions who participated there. 3 infections in pneumonia, diarrhea, and malaria account for 45% of all deaths among children. This is relevant to this forum, but there are total 18 anything which is related to child health and priority. This was developed by a group of partners, and many of you are here who participated in this. And so this is our IP on behalf of 164 member society. We 18-point commitment, and people took oath. And I am again highlighting something relevant here. Advocate for the unfinished agenda of child survival and support scaling of coverage of select intervention across the continuum of care in countries lagging behind. And we know what are the countries lagging behind. The second was immunization. We very much support the immunization agenda 2030 strategy and reaching the zero-dose children for advocating immunization necessary efforts essential to addressing universal health coverage and increasing coverage of the vaccine targeting the leading causes of children, that is pneumonia, diarrhea, and malaria. Environment and climate change. See, the good thing is good sanitation and these things have improved and brought down the incidence of diarrhea, not the viral causes, but bacterial causes. But on the other hand, and the climate change and environment has made them more susceptible to the pneumonia and more susceptible for many respiratory diseases. So this is again one of the focus area. Quality of care is very important. Patient safety and quality of care, access to the essential medication, and so this is what we had in 18-point agenda. I call upon here all the partners, wherever you need us, in any country. We have many good colleagues, pediatric society colleagues here. Wherever you need us, as a pediatrician, not as only as an expert, because we are not only the doctors, we are also advocates of the children. Because I'm so happy to see so many partners here, but we do that all the time, that we advocate for the rights and health of the children. And you will, any country, just reach out to us and we will connect you to our society or pediatrician. And no discussion on pneumonia can be complete without involving pediatrician. So this is last session, but it's a very important. And thank you very much for involving us. Thank you.
And Dr. Thacker is right, because after all, our pediatricians are the ones who have real care. Sorry. It was a puzzle to see. And Dr. Thacker is so right, because pediatricians are so
como decía, los pediatras son fundamentales en este esfuerzo. Pues hemos llegado a un momento muy especial en el programa. Ya hemos tenido dos expresiones de compromiso. Ahora vamos a oír el de los gobiernos nacionales, que han asumido también una serie de compromisos.
And I really hope you're going to encourage them, because they have done a lot of work and they have really pushed to make these commitments real. So the first set of governments, Burkina Faso, Chad, DRC, and Guinea. So if I could ask Burkina Faso, you're a whole country now, to come to the podium to read your commitment.
Bonsoir à tous et à toutes.
Good afternoon, everyone. This Second Global Forum on Childhood Pneumonia 2023 has revealed the high number of diseases from malaria. And
In view of these numbers, Burkina Faso commits to develop and implement a strategy to guarantee the availability of pulse oximeters at health facilities and to accelerate the construction of medical oxygen plants in hospitals. We also commit to improve the availability of fundamental drugs for the treatment of pneumonia and other respiratory diseases, and we will pursue the implementation of our community strategy for health and to recruit more community-based health workers. The Ministry of Health and public institutions in Burkina Faso will ensure that equipment will, technical medical equipment will be acquired and to foster the production of therapeutical oxygen and to gap the bridges or to bridge the gaps in health, universal health coverage and health services by the hand of our technical and financial partners. Thank you.
The government of Chad.
Bonsoir.
Good afternoon. Considering the high level of mortality of children under 5, the Chadian Ministry of Public Health and Prevention will demand Gavi to introduce a new program for 2024 to apply PCV and rotavirus vaccines as of 2024. And also, the Ministry of Health in Chad will make sure that in all policies the list of basic drugs be made available to all health centers, including pulse oximeters, therapeutical oxygen in all health centers and pediatric services, to make sure that all units have pulse oximeters, oxygen, and qualified staff to prevent and treat pneumonia and diarrhea. In pursuit of these efforts, the Chadian government requests greater flexibility from donors
à l'acquisition des oxymétries de pouls et un soutien à l'oxygène ainsi qu'une amoxicilline adaptée pour les enfants au Fonds mondial dans le cadre du C19RM et du programme RSSH. Ces investissements augmenteront l'impact de la stratégie nationale de lutte contre la pneumonie élaborée par le pays et le ministère invite de ce fait tous les partenaires à soutenir sa mise en œuvre complète.
Approved by the ministry, and we urge all our partners to develop these solutions jointly. Thank you.
The Democratic Republic of Congo.
Merci. Pour accélérer rapidement la baisse de la mortalité infantile
to quickly accelerate the decline in child mortality, the Democratic Republic of Congo's Ministry of Health
visera à réduire le nombre d'enfants
of zero-dose children by 30% in its 11 provinces by 2025 in association with Gavi. The ministry has decided to increase national resources to bring vaccination coverage with pentavalent measles and PCV vaccines to record levels, to reinforce the access to diagnosis by pulse oximeters and therapeutic oxygen. The Ministry of Public Health and Prevention of the Democratic Republic of Congo will make sure that all policies, guidelines, and applicable drugs used in child health will include
pulse oximeters and oxygen treatment. And it will also make sure that health centers and pediatric services are duly equipped with pulse oximeters and medical oxygen so that well-trained staff can handle this equipment to diagnose and treat sick children. The ministry will equally draft a plan to enhance access to amoxicillin-based drugs to treat pneumonia and to cooperate in the creation of new national statistics. To fund these efforts, the ministry demands the support from the World Fund in the framework of the 619 RM SSSH to sustain the availability of medical oxygen and to reinforce our country's health system. Thank you.
Now, there's an extra here because, unfortunately, the government of Ethiopia was unable to make it to this meeting at the last minute, but they sent through their commitment and asked for it to be read out to all of you. So I'm just going to read their commitment. Ethiopia intends to achieve SDG 3.2 by 2030 with an ambitious plan to reduce child pneumonia and other deaths by restoring PCV, pentavalent, rotavirus, and measles coverage to pre-pandemic levels of above 90%. By increasing the supply of vaccines and antibiotics through local manufacturing, and by increasing access to pulse oximetry and oxygen therapies for newborns and children. The ministry will target additional support to the children at greatest risk of death, including the estimated 1.1 million zero-dose children, and will work with partners to reach those living far from health services to address the currently very low rates of care seeking for children with pneumonia symptoms. The ministry will ensure that COVID-19 pulse oximetry and oxygen supplies are redeployed to benefit sick children. To help finance these efforts, the ministry will apply for pulse oximetry, oxygen support, and amoxicillin dispersible tablets from the Global Fund as part of the C19RM and the RSSH programs. That's Ethiopia. And now the final from this group, if I could welcome the government of Guinea to the podium.
Le ministère guinéen de la Santé
The Ministry of Health reaffirms its commitment to achieve SDG 3.2 and will rapidly accelerate the decline in child mortality by rounding up its national immunization strategy and integrating PCV and rotavirus vaccines into the routine vaccination schedule by 2024. The ministry will work with BAT and other partners to fill the demand of the population and the assistance requested from Gavi to achieve SDG 3.2, to reinforce the capacity of health agents in the struggle against pneumonia, particularly in distant, remote areas. The ministry will provide the supply recommended by the supply of antibiotics recommended by the WHO, and it commits to deploy the resources to make sure that women and mothers understand the seriousness of these diseases and waste no time in bringing attention to their sick children. The ministry also commits to seek the co-funding of Gavi as a fragile country, and it also commits to request assistance to provide medical oxygen and amoxicillin for pediatric use in the framework of the program C19RM in its health system. Thank you very much for your attention.
And so thank you very much to that first group of commitments: Burkina Faso, Chad, DRC, Ethiopia, and Guinea. Thank you. And now for the second group of commitments, we have India, Indonesia, Mali, and Mozambique. And it's my pleasure to welcome, first of all, India to the podium.
These are commitments made by Ministry of Health and Family Welfare, India, to the children under 5 in India at risk of or sick with pneumonia, diarrhea, malnutrition, or any other sickness. India is on track to deliver and achieve SDG 3.2 and will continue to prevent child deaths by improving child health services and by increasing coverage of PCV to 90% in every district by 2030, and by restoring DTP and measles rubella vaccination coverage to pre-pandemic level of above 90%. Pneumonia accounts for mortality of 12.6% in newborn and 17.6% in children. At present, India commits to bring this down. India will continue to strengthen facility-based newborn and pediatric care services at district and sub-district level to treat children with pneumonia and other health conditions. The flagship social awareness and actions to neutralize pneumonia successfully, the SARS campaign from November to February each year will continue to deepen its engagement with caregivers and healthcare professionals and the community to increase community understanding of the links between child malnutrition, exposure to air pollution, indoor as well as outdoor, and pneumonia death. All relevant child health policies, programs, guidelines, and immunization program will be implemented universally to reach each and every child to achieve SDG agenda of survive, thrive, and transform of each child. Thank you.
Thank you. Government of Indonesia.
Commitment by the delegation of the Republic of Indonesia. The pandemic didn't stop us from ensuring every child in Indonesia in getting their right to survive and thrive. We even grew stronger by achieving SDGs 3.2. Despite the challenges, the Indonesian government has accelerated its nationwide introduction of PCV vaccines from 2024 to 2022. Kicking off from this, the Indonesian government will continue to work together to reduce child deaths by driving PCV, DTP, and measles rubella coverage rates to above 90% in every region. This commitment was stated in the strategic plan of the Ministry of Health 2022 and 2024 and will be released in the National Action Plan for Pneumonia and Diarrhea in 2023 to reduce child deaths from pneumonia and diarrhea. In addition to immunization, the government of Indonesia have conducted various of interventions to control etiology and risk factors of childhood pneumonia. These interventions include the promotion of exclusive breastfeeding, reduction of low birth weight, improvement of child nutritional status, controlling indoor pollution and improving housing, improving health-seeking behavior, improving health access to achieve universal health coverage, improving quality and coverage of pneumonia case management in all health facilities, including to ensure the availability of pulse oximetry and an adequate of supplies of medical oxygen in every primary healthcare center, and ensuring financial sustainability for pneumonia prevention and control. Since 2022, the Indonesian government has been committed to implement health system reforms, including special effort will be made to reach the large population of zero-dose children. Furthermore, the Indonesian government committed to increase domestic production to increase access to a steady supply of affordable childhood vaccines. Every child deserves a healthy, productive, and happy life. Thank you.
Thank you, Indonesia. And now the government of Mali.
Bonsoir. Le ministère de
Good
la Santé et du
afternoon.
Développement social de la République du Mali s'engage
Ministry of the Republic of Mali commits to guarantee access to clinical or medical oxygen to treat hypoxia or hypoxemia, and to provide pulse oximeters to 50% of health centers before 2024. The government commits to draft a national oxygen plan to guarantee ongoing supply of amoxicillin and ozone and medical grade oxygen in all of its healthcare centers. Also, mobile units for difficult access areas, particularly in areas of DPIs stemming from war conflicts. The government also commits to advance the plans, their plans of fundamental care and the progressive implementation of a model of proactive health agents to significantly reduce the mortality of children under 5, so that we can proudly attend the next meeting of the 2030 agenda. The Mali government commits to increase its commitments progressively by 2025.
Mozambique.
Thank you. I read the commitments by Mozambique. The Minister of Health will continue to increase the coverage of PCV, DPT, and measles vaccines to over 90% by 2030 to accelerate progress towards SDG 3.2. It will continue to implement actions to raise community awareness about the risk of pneumonia in children, together with other causes of child morbidity and mortality, especially malaria and HIV. The Minister of Health will continue to work with its partners to ensure a regular and equitable supply of vaccines against pneumonia, including for approximately 330,000 children currently estimated to have zero dose, as well as other actions to reduce all vaccines preventable diseases. For this purpose, starting in 2033, the Ministry of Health will implement its vaccine recovery plan and include pulse oximetry in the IMCI guidelines. To improve diagnosis and treatment access, the Ministry of Health will work with its partners to ensure the availability of pulse oximetry and oxygen in health facilities in accordance with the national plan, and continue to work to ensure a regular and equitable supply of medicines for the management of non-severe pneumonia at the community through community health workers. The Ministry will continue to strengthen the Committee of Experts for Immunization to to carry out its role with impartiality, transparency, and quality. Finally, the Minister of Health will remain alert to all opportunities to mobilize resources for actions that contribute to improving child survival. Thank you.
Thank you to the governments of India, Indonesia, Mali, and Mozambique. Thank you. And then the final group of government commitments today, please welcome Nigeria, Sierra Leone, and Somalia. You're worried about the chairs? No. And please, to start off the commitments from this group, can we please welcome the government of Nigeria?
Good evening, everyone. On behalf of the government of Nigeria, I speak. As the 7th most populous nation globally, with over 40 million under 5 children, Nigeria is committed to reduce the under 5 mortality rate by rapidly increasing coverage of pneumococcal, measles and diphtheria, tetanus and pertussis vaccines to above 90%, and will lead efforts to reduce the number of zero-dose children by 30% with vaccinations, nutrition, and other interventions within the ongoing initiatives. The ministry would also increase the pneumonia care second rate to above the current rate of 40% by increasing community awareness. To improve survival rates for sick children, the ministry will build capacity for frontline health workers on integrated management of childhood illnesses. The ministry will strengthen access to diagnostics tools, including pulse oximeters, and ensure steady supply of amoxicillin dispensable tablets to treat non-severe pneumonia at community and first-level facilities. To ensure that health facilities are equipped with medical oxygen, the ministry will revise and strengthen the national oxygen strategy to ensure a robust child survival action agenda forms part of Nigeria's third health sector strategy plan from 2023 to 2027 and will support execution of the National Pneumonia Control Strategy and Implementation Plan. To finance this agenda, the ministry will apply for pulse oximetry, oxygen support, capacity building, and child-friendly amoxicillin from the Global Fund. And as part of the COVID-19 response mechanism and the RSSH programs, and work with the Global Financing Facility and other funders to ensure national child health priorities are adequately supported. Thank you.
Thank you, Nigeria. I have another commitment to read out to you. Unfortunately, at the last minute, the government of Peru couldn't join us here. But again, they have sent their commitment and wanted it read out to all of you. And I think we should send our congratulations to Peru for having already achieved SDG 3.2. So, their commitment. Despite having achieved SDG 3.2, the Peruvian Ministry of Health will continue to reduce child deaths by driving PCV, DTP, and measles coverage rates to above 85% in every region. The ministry will also focus on the social determinants of poor child health, especially malnutrition and air pollution in specific subpopulations of children in the colder and more rural Andean region. The ministry will strengthen nutrition services to these populations by increasing growth monitoring and treating wasting and anemia. The ministry will improve the diagnosis and treatment of pneumonia in these and other populations by improving access to pulse oximetry and medical oxygen, and by ensuring that new COVID-19 supplies are redeployed to NICUs, pediatric wards, and child health services. And please, the government of Sierra Leone.
Good afternoon. The Sierra Leone Ministry of Health and Sanitation has released a new child survival action agenda with 21 specific actions focused on protecting the children at greatest risk of death from pneumonia, malaria, diarrhea, and malnutrition. The ministry hereby commits itself to rally all the relevant government stakeholders, national, regional, and international partners to integrate the financing and quality delivery of the highest impact child survivor interventions, including vaccination, nutrition services, the integrated case management of sick children in the community and facilities. To strengthen the governance of child survivor, the ministry will create a new overarching child health program and reactivate the Child Survivor Technical Working Group that includes several government ministries. Further, the ministry commits to ensure that all relevant child health policies, guidelines, and essential medicines lists include pulse oximetry and oxygen, and that health facilities and pediatric hospital wards are equipped with pulse oximeters and oxygen, and train head staff to diagnose and treat sick children. To help finance these efforts, the ministry will apply for pulse oximetry, oxygen supply, and child-friendly amoxicillin from the Global Fund as part of the C19 portfolio optimization and RSSH programs, and will work with the Global Financing Facility and other funders to invest in the renewed Child Survivor Action Agenda. Thank you.
And happy Independence Day to you again. And the final commitment from this group, actually, no, it's not the final one, but we'll hear from Somalia.
Good evening. I'm here on behalf of our director to communicate with the commitment of Somali government to rapidly accelerate decline in child mortality and progress towards Sustainable Development Goal 3.2. The Minister of Health of Federal Government of Somalia commits to implement different interventions to end preventable death of newborn and children under 5 years. This will be achieved through rigorous implementation of our strategy, health sector strategy, the rollout of essential package of health services, the community health work strategy, and also it commits to capacitate and increase the skills of community health workers and health workers to promptly diagnose and treat pneumonia at community level as well as health facility. And also we commit to expand the availability of oxygen to more health facilities. Essential supplies like amoxicillin and pulse oximeter will be available, and we will readily use the available global fund C19RM. The government, with support of his partners, will apply Gavi to introduce PCV and rotavirus into routine immunization this year, 2023. We are grateful to hear the announcement of Gavi for removing the co-financing component for PCV and rotavirus. We always thank our donors and partners for their continued support to improve the health and well-being of Somali people. Thank you.
And the final commitment comes from the government of South Sudan, who can't be here, but again, ask for their commitment to be read to you. The South Sudan Ministry of Health will apply to Gavi in 2023 for introduction of the PCV and rotavirus vaccines in 2024. The ministry will work with many partners to operationalize the delivery of these vaccines, for example, the Boma Health Initiative, the ZIP program, and to expand successful approaches, for example, the 2013 PCV catch-up campaign in Yida Camp, Unity State with MSF. Nutrition services will be integrated with vaccine delivery, as outlined in the government's Nutrition for Growth Commitment, Tokyo 2021. And this includes a 10% increase in the national nutrition budget. The ministry will continue to strengthen pneumonia treatment by increasing access to pulse oximetry, oxygen, and antibiotics. To finance these efforts, the ministry calls for time-limited relief from the Gavi co-financing requirement as a fragile country and will apply for pulse oximetry, oxygen support, and child-friendly amoxicillin from the Global Fund as part of the C19RM and the RSSH programs. So thank you to these governments. So Nigeria, Peru, Sierra Leone, Somalia, and South Sudan. And so now we are really drawing very close to the end of this second global forum on childhood pneumonia. We are going to have some closing addresses from partners who've been so supportive of making this forum happen. And once we've had those closing addresses, I will give one final little bit of instruction before you go. So please welcome to the stage Ms. Ariadna Bardolet, Director of International Programs, the La Caixa Foundation.
Good afternoon, everybody. First of all, let me tell you that for La Caixa Foundation, it has been a huge pleasure to host this second edition of the Global Forum on Childhood Pneumonia. I would like to thank all the participants, the governments that traveled from far, and that have demonstrated that they are strongly committed to pneumonia and to child survival. As well as I would like to thank the Gates Foundation and all the partners involved, ICE Global, UNICEF, Save the Children, Every Breath Counts, Gavi, USAID, PATH, Clinton Health Access Initiative, Child Health Task Force, and UNITAID. I also would like to ask for a big round of applause for the team that has been in front of the organization of this forum. We have seen a lot of passion from them. Thank you, Magda, Rebecca, Marta, Caixa Forum family, communication and marketing, protocol, all those involved. And thanks also to Quiero Communication for the excellent work done, and to Theo for such an amazing facilitation of this forum. A special thanks to Liz for your leadership and for being so instrumental in coordinating all of us. That's not easy. As you have heard, these days, La Caixa Foundation is strongly committed to global health, and fighting pneumonia is part of our past, present, and future. We cannot allow that still today, every 42 seconds, a child dies of pneumonia, a preventable disease. We cannot allow that every 20 seconds, a child dies for not having vaccines. Children are the future, and we need to protect them. It's our responsibility, and we cannot fail. It has been great to be part of these 2 days meetings because we have heard a lot of commitments, a lot of alliances, a lot of efforts from countries, civil society organizations, international organizations, private sector. We have learned the importance of long-term partnerships And we have learned the importance of alignments of the strategies for a higher impact. And this is very important because the investments and results achieved are remarkable. However, we still need a long way to go. As Her Royal Highness said in her open remarks, from La Caixa Foundation, we are going to continue to include the fight against pneumonia as a priority in all the Foundation's international cooperation global health programs, call for proposals, events, campaigns, in order to raise more funds, but also more awareness. And we will also maintain the support to Gavi in partnership with the Bill and Melinda Gates Foundation and ICE Global to prevent pneumonia with vaccination through the Alliance for Child Vaccination. And finally, I would like to finish my intervention with a sentence that we say at La Caixa Foundation. It's not progress unless we all make progress. So let's continue working hand in hand, working together with all of you to progress, to change life, and build better futures, being sure that no child dies of pneumonia. Thank you very much.
Thank you so much for those great words. And now I'd like to introduce to the stage Dr. Gail Rogers, Deputy Director Pneumonia of the Bill and Melinda Gates Foundation.
Your Royal Highness, Infanta Cristina of Spain, Excellencies, dear colleagues and friends, I want to thank each of you for participating in this very successful second pneumonia forum. Over the past few days, we've discussed everything from child survival and primary health care to the power of expanding access to pneumonia-preventing vaccines. We spoke about the incredible tools at our disposal today, such as pneumococcal conjugate vaccines and the ones that are forthcoming, such as the first RSV vaccines for pregnant women. Coming out of these sessions, I'm very encouraged by the progress that is possible when country leaders, UN agencies, civil societies, scientists, donors, and the private sector work together to enact change. We're grateful that you have joined us in our effort to confront one of the most dangerous threats facing children in low and middle income countries. I want to recognize the incredible commitments that have been made throughout these 2 days. These include introducing PCV into countries that had not yet introduced PCVs, expanding access in those countries that have, expanding access to pulse oximetry, oxygen, and antibiotic therapy, which are crucial, reducing the number of zero-dose children, and providing access of vaccination in humanitarian and very fragile situations. And finally, developing national action plans to improve child health survival more broadly. Thank you for these commitments and for the actions that you will be taking to protect children from this deadly disease. As you are well aware, the Bill and Melinda Gates Foundation remains steadfast in our commitment to decrease pneumonia deaths. As you heard from Dr. Klugman at the opening, over the next 18 months, the Bill and Melinda Gates Foundation will grant $200 million in funding to support the development of new vaccines, as well as the delivery of vaccines to prevent pneumonia, meningitis, and neonatal sepsis. This includes next generation PCVs. This includes next generation PCVs and other pneumonia preventing vaccines such as RSV. A critical part of that investment is ensuring that new vaccines are more accessible and affordable, and optimizing PCV dosage schedules to sustain programs. Gavi, WHO, UNICEF, and a global network of partners play a crucial role in making vaccines more affordable and supporting country introductions and scale up. We are very proud to support this work. To support countries who've committed to PCV introductions during this forum, we have committed funding to several partners to provide technical assistance with applications. Other Gavi-eligible countries can access this same support for their new vaccine introductions or for switch applications. So please reach out if you're interested. Once again, I really want to extend my heartfelt thanks to the government of Spain for making child survival a priority and hosting this forum. Thank you to all the organizations and countless staff members who helped organize and facilitate the forum, and Leith, especially you, for organizing all of us to make this a success. Special thanks to Madrid, who has delivered this weather, which is unbelievable. I don't know how that happened, but we look forward to returning to Madrid in June for Gavi's 2023 High-Level Summit on Immunization, Raising Generation Immunity. I hope all of you are leaving after these 2 days as energized and as optimistic as I am. I know we have our work cut out for us, a lot of work in front of us, but we have critical engagement and leadership from governments and partners, as well as the powerful tools to make this happen and to stop childhood pneumonia. Let's take advantage of this momentum created here by everybody and not squander this opportunity. I look forward to working with all of you in the coming months to make pneumonia prevention vaccines accessible to every child, regardless of where they live. Thank you very much.
Thank you, and I hope Madrid produces the same warmth for your replenishment, for the Gavi replenishment, and not just the weather warmth, but the warmth of welcome, which has been wonderful. And now we have Christiane Munduate, UNICEF representative, Nigeria.
Good afternoon. UNICEF is inspired by the community that has come together at the second Global Forum on Childhood Pneumonia, and very grateful to everyone who has joined us for this vital event. Thank you, Your Highness. Thank you to the co-host, the Bill and Melinda Gates Foundation and the Caixa Foundation, and all the partners that were involved in a very robust agenda and fruitful discussion. Thank you also to all the partners who have made courageous and transformative commitments today to stop pneumonia. I must begin by stating our unequivocal commitment to child rights, which is also about child survival and is a fundamental element to guarantee the rights of all children everywhere. This event coincides with the World Immunization Week, with governments and partners around the world taking action for childhood immunization and ending preventable childhood diseases like pneumonia. Building on our urgent call for action to tackle immunization backsliding, today UNICEF fully endorses the Child Survival Action Initiative and is proud to make the following commitments to accelerate action on ending pneumonia and other vaccine-preventable diseases through primary health care. First, we commit to community health. This is a UNICEF corporate priority by our executive director, aiming to have more paid community health workers to deliver essential health and nutrition services at the last mile. We will mobilize globally bring countries together regionally, and in countries we commit with all partners to work at national, subnational, local levels, and most importantly, at community level. We commit to provide catalytic support to governments who endorse this agenda in countries, working with key stakeholders to advocate for major investments, both public and private, for the national plans. At UNICEF, we are well placed with public and private sectors to drive accelerated actions. We cannot just do it alone. We need all of you. We need a strong partnership and network. Within this, we will have a strong focus on West and Central Africa and ensuring the poorest and most marginalized community, especially women and girls, will continue being at the center of our work. We are driven by measurable results and are holding ourselves strongly accountable. Pneumonia-seeking behavior is a tracer and a core indicator in all high-burden countries for progress on child survival. On vaccine, last week UNICEF launched the State of the World's Children 2023, as some of our colleagues have already mentioned in the forum, called for every child vaccination. The report examines what needs to happen to ensure that every child everywhere is protected against vaccine-preventable diseases. The report also examines the way in which primary health care can be strengthened to better support immunization services, critical to ending preventable deaths from pneumonia. We will continue supporting countries with the highest number of zero-dose children to catch up on unvaccinated children, restore services, and boost essential immunization coverage rates. We will focus on building political will for and providing technical support, capacity building, and demanding generation in the remaining countries preparing to introduce PCV, rotavirus, and other new vaccines which are essential for child survival. Our comprehensive multisectorial approach will always focus on strengthening primary health care to deliver all essential health services which can address a comprehensive range of health inequities and improve the quality and efficiency of service delivery. On sustaining and scaling oxygen access, in 2023 and 2024, UNICEF will provide with this support and in partnership with all of you, will provide continued support to governments in low and middle-income countries to sustain and further scale oxygen systems and ensure access to pulse oximetry and oxygen therapy for children. All of this is underpinned by a commitment to intensify support to governments to end preventable deaths through strengthening primary health care and by ensuring comprehensive, integrated preventive, promotive, and curative health and nutrition services, especially, as I mentioned before, at the community level. In closing, I would like to congratulate all governments and organizations present today for their work and their commitment on child survival, which is one of the most fundamental child rights. Thank you.
Thank you. And please, if we can now welcome to the podium Mr. Borja Luis Cabezon Royo, the Ambassador for Global Health for the Spanish government.
Hello. How are you? UNICEF teams told me that you are very tired. I have excellent news, good news. I'm going to speak in Spanish. Me gustaría comenzar
I would like to start
felicitando a la Fundación
congratulating La Caixa
a la
Foundation,
Fundación Bill y Melinda Gates,
Bill and Melinda
UNICEF por la
Gates
celebración de la segunda
Foundation
edición del Foro
for
Global
the second Global
sobre
Forum
neumonía
on Childhood Pneumonia.
Quiero agradecer también
I
la
would like to
presencia
thank as
de Su Alteza
well
Real,
the presence
la
here
infanta
of Her
Doña
Royal Highness
Mi
the
invitación a
Infanta
participar,
Doña
y a todos
Cristina
los
for
ponentes y
participating
representantes
here
del
and
Gobierno
all
español,
the other participants and
funcionarios de los
speakers
ministerios
from
de
the Spanish
Sanidad de
government,
países
of the
con alta carga de
Ministry
neumonía
of
infantil,
Health of many,
gobiernos
many
donantes,
countries,
empresas,
donor
instituciones
countries,
académicas
companies,
y
the
sociedad.
academia, and the civil society
Gracias.
organizations. Thank you very
Gracias por
much
este
to
foro,
all of you for celebrating this
enorme
forum,
y
for
valiosa
your
vocación.
very
Es urgente
important
acelerar la consecución
contribution.
del
It
objetivo
is very
mundial de
important
supervivencia
to
infantil,
reach
un
the
compromiso global
global
inaplazable
challenge
de la humanidad,
of
con un
decreasing
derecho reconocido en la
childhood
Convención sobre los Derechos
death,
del Niño,
especially included
sintetizado
in the
en el
rights of
ODS
children,
3.2,
included in
proteger,
the
prevenir,
SDGs
diagnosticar
3.2
y
to
tratar la
prevent,
neumonía
to
infantil con el
diagnose and to
objetivo de
treat
poner fin
childhood
en 2030
pneumonia in order
a las
to
muertes
finish
evitables
with these
de recién nacidos
preventable
y de niños y niñas
diseases
de
of
menos de 5
children
años.
under 5
La
years old.
neumonía, que se ha
Pneumonia,
comentado aquí,
as it has been
es la
said
principal
here,
causa
is one of the
de muerte
main
infantil por
causes
infección
for
Casi 2.000 niños
children's
mueren cada
death,
día de neumonía.
bacterial,
Un niño o
one
niña
every
cada
4
45
years,
segundos.
and one child
No
every
puede
45 seconds. That's unbearable.
No obstante, los avances en la vacunación infantil se han
Nevertheless,
estancado
the
a nivel global.
advances in
Una realidad compleja
global
que la pandemia ha
vaccination
evidenciado y
has
exacerbado
suffered
con grandes
stagnation,
desigualdades
and
en el
it
acceso
has
a la
been
vacunación
treated
infantil en casi todo el
inequally
mundo.
in access to
Entre 2019 y 2021,
children
48
vaccination.
millones de niños y
In
niñas no
2021,
recibieron ni una sola
41
dosis.
million children
Cero
did not
dosis.
receive
Y los niveles de
not
cobertura
even
de
a dose,
vacunación
a zero
disminuyeron
dose, and the coverage
en
levels
112
diminished in 112
En 2021,
countries. In
los datos son más
2021,
alarmantes.
figures are
25
even
millones de
more
niños y
alarming.
niñas no recibieron la
25
vacuna contra la
million
difteria,
children did not
tétanos y
receive
la tos febril.
vaccine
Y la cobertura de la primera dosis
on
contra el sarampión cayó
diphtheria,
al 81%,
pertussis, and
el
tetanus,
nivel más bajo
and
desde el año 2008.
that was one of the
No
lower
puede ser.
levels since 2020.
España es uno de los países donantes interpelados para
Spain is one of
impulsar
the
los
donor
esfuerzos
countries that
encaminados
has
a
been
luchar
urged
contra la
to
neumonía
fight
infantil en todo el mundo.
against
En este sentido,
child
quiero destacar la
pneumonia,
estrecha
and
colaboración
I would
de
like to
España
focus
con
the
Gavi,
close
la Alianza para las
collaboration of Spain
vacunas,
with Gavi,
como
the
testimonio del
Alliance
compromiso
for
de mi país
Vaccinations.
en proteger a
And
generaciones
I
de
would
niños
like
y
to
niñas
protect
de la mortalidad infantil,
children
apostando
in
por
my
la
country
inmunización.
for
Durante
betting
las dos
for
últimas décadas
immunization.
hemos trabajado
And
con
during the
Gavi
last
y
2
sus
decades,
socios
we've been
para
working with
proteger
Gavi
a más de 1.000
in order
millones
to
de niños
protect
y niñas de enfermedades
millions of
infecciosas
children of
potencialmente
infectious
mortales
diseases
como la
that could be
neumonía.
potentially lethal,
Con un
as for
compromiso
example pneumonia,
de
with the
290 millones
commitment
de euros
of
a lo largo de
290
30
million
años
euros
a través del mecanismo
throughout
innovador
30 years through
del Servicio
the
Financiero
new
Internacional
mechanism
para la
of the new
inmunización.
system for
España ha
immunization,
intensificado sus
and
esfuerzos
Spain
en el ámbito
has
de la salud global.
intensified its efforts
Además,
in global
desempeñó un
health.
papel importante
And
mi
Spain
país
has
en el apoyo
played
a
a
la
very
vacunación
important role
durante la
in
pandemia de la
supporting
COVID-19,
vaccination and
al ser
vaccine,
el quinto mayor donante de
vaccines
vacunas a través
campaigns,
del
and
mecanismo
Spain was a fifth donor
con más de
of
60 millones de
vaccination
dosis
through a
donadas,
special
principalmente
vaccine
a
donation
países
system,
de ingresos
especially
bajos y medios
to lower,
El apoyo
low
estratégico
and
a
medium
las
income
iniciativas
countries,
multilaterales como
supporting
Gavi
with the
agregan los esfuerzos
associations
de
or
la comunidad
alliances as
internacional
Gavi
en materia
empowers the vaccination and immunization for both the normal schedule plus the additional program of special vaccines. Spain is a special country that is fighting and committed with 10 million euros for a malaria vaccine. And this is why we shouldn't forget that there's still a long path to walk. We still have to report that we are very proud in Spain to celebrate in Madrid the Gavi vaccination program and Congress that will be celebrated in
la
Madrid.
revisión intermedia del ciclo estratégico de Gavi 2021-2025 y brindará una oportunidad clave aquí en Madrid para que los líderes de salud global hagan balance del estado de la vacunación en los países de bajos ingresos para ampliar la protección de las vacunas contra la neumonía y escribir juntos el próximo capítulo de la inmunización mundial. Estos últimos meses, España ha reafirmado su compromiso con el desarrollo de una nueva estrategia de salud global, con el objetivo de anticipar la capacidad de respuesta a futuras crisis sanitarias y posicionar a España como líder internacional en cooperación sanitaria. Estamos revisando el borrador final para poder presentar nuestra estrategia en plena presidencia de la Unión Europea. A comienzos de 2023 se aprobó la Ley de Cooperación para el Desarrollo Sostenible y la Solidaridad Global con un 0,7%. España participa en la iniciativa Team Europe Africa sobre seguridad sanitaria sostenible con un enfoque
with a One Health approach to reinforce existing structures in sub-Saharan Africa. In this context,
junto a la Comisión Europea, una iniciativa en el marco Unión Europea, América Latina y Caribe,
the framework of European Union, Latin America and the Caribbean on health resilience and the production and distribution of vaccines aimed to support regional efforts, ongoing regional efforts like the self-sufficiency plan for health. As you can see, we're unstoppable. I was never told that being an ambassador for global health would require so much activity. But I need to tell you, we will not stop. We will not stop. So you can count on us. You can count on Spain. With strategic partners like you, we need to remain unstoppable. We need to press on ahead. In July 2023, Spain will take up the presidency of the European Union Council. This will be a new opportunity to promote, along with our European partners, the ambitious agenda of the European Union, where global immunization will play a starring role. And to close, I would like to thank you once more for your attendance and participation on this forum on childhood pneumonia, encompassing all relevant actors, governments, partners, and civil society as part of a single joint target. And our global purpose is saving millions of lives of children under 5 in the next decade.
Miren, mi hijo
Ladies and gentlemen, my son just turned 6.
Es un privilegiado.
And he's a privileged child, as I always dream.
Sé que soñar en un mundo mejor
I know that dreaming of a better world is a good thing to do. But thanks to this forum made me realize that dreaming together enables us to address specific causes. And this is one of those specific causes. Let us all dream together so that all children can actually turn 5 and 6 and blow their 6th birthday candles with a smile.
Thank you, Ambassador. So we really are coming very close to the end now. There's one final presentation at the podium. And then I will be introducing our closing video. After the closing video, we'd like to ask you all to meet in the foyer in front of the declaration so that we can take a group photo and really celebrate
the success of the 2 days you've spent together. So please, when the video is finished, please get up and go into the foyer and stand by the picture so we can get that photo taken. But before we get there, it's my very great pleasure to introduce again Her Royal Highness, the Infanta Cristina of Spain. And to join her, someone that you've all, I think, wanted to say thank you to, Leith Greenslade. And so just before, if you could hold the video for 1 minute, I just want to say 2 words before the video comes on. I wanted to say thank you to all of you, everybody who's played a part in this forum. Thank you for your hard work before you got here, your hard work while you've been here, and the work that we know that all of you in your different roles will be doing when you get back to your homes and your organizations. As we close this forum, I just wanted us to remember, we know what we need to do. We know where the challenges are, we know where the opportunities are, we know where the gaps are. We've had 37 amazing commitments that have been made at this forum. Please, let's remember, as professionals, as men and women, as parents, as human beings, we've made promises to the children of the world. Let's make sure we hold ourselves, our governments, our organizations accountable, and let each of us, working together, actually go out there and build that world where every child survives and thrives. If we can have the closing video, please.